All right, so now we're recording. All right. So anyway, just because all in my business, today we're going to be covering the skeletal system, the second part of orthopedics. Remember, muscles was the first part, and again, those same word parts, ortho, I think. I changed them up here. Osteo is bone, like excuse me, osteoma, a tumor on the bone, or osteopathy, a disease of a bone. So osteo means bone, and chondro is cartilage, as in the term chondromalacia, softening of the cartilage in the joints, and we're going to be talking about that today. Arthro is joint. Can anybody think of a word that includes that word part, arthro? How about
Arthritis.
arthritis? All right, yeah, everybody's like, okay, arthritis or arthro is joint, and then myelo is bone marrow. Like in osteomyelitis, inflammation or infection of the bone and the bone marrow. Myelo is bone marrow. All right. Now, the purpose of this system is to provide structure, to give the body a framework. And also, we store calcium in our bones. We talked about that. Calcium is what gives the bone its solidity or its strength, and but it also is important for our muscle function. So we have hormones to make sure that we have the right amount of calcium in our blood and the right amount in our bones. If you end up with a condition where the calcium is being pulled from your bones in too high a rate, or too much calcium is being pulled from the bones, it's going to leave holes in the bones. And anybody know what condition we call that? Holes in the bones. It's more common in women, Caucasian and Asian women.
Multiple sclerosis.
No, osteo something.
Paralysis.
Osteoporosis. The bones have pores in them, or openings in the bones, osteoporosis. So if you are pulling too much calcium from the bones, you can end up in the state of osteoporosis. Again, it's more common in women, Asian, and female. Okay, now there is, I think we mentioned this before in class, I'm not sure, but I might have asked you before. How many of you drink as much milk as you did when you were kids? Most of us do. Yeah, some of us do, but most of us don't. Some of us do because we like the calcium or we like milk. But when we were kids, we drank so much milk because it contained the high calcium that we needed as our bones were growing. So we craved milk the same way a pregnant woman craves pickles if her iron is low or something like that, or the same reason your dog eats grass when you let him out in the yard. They driven by cravings. So when you were a kid, you come home from school and down a big old glass of milk, and when you ate your cereal in the morning, you drink the milk afterwards and all of that. So some of us, every now and then, I'll have a bowl of cereal, and I eat the cereal and pour the milk down the sink. Okay. What is this? Are y'all chatting? Is that what y'all are doing? See, y'all busting now. You keep down with 5 alerts, But anyway, yeah, y'all talking behind my back's what y'all doing. Y'all like, don't he look little now? I'm sitting down in the chair. I'm like, man, I feel little, y'all. But anyway, what?
I don't see the screen. Like, I don't see nothing on your screen, on my
Y'all
screen.
Y'all don't see me sharing this skeletal system PowerPoint?
I see you, but I don't see this PowerPoint.
You don't?
We just see a girl running on the beach.
Yeah.
Oh, why is that happening?
I don't think you're mirroring.
Oh, I don't think I'm sharing. Here we go. That screen right there. You seeing it now?
Yes.
Yes.
Okay. All right. Okay. So it's all there. Yeah. Anyway. On the beach. Anyway. So that is boom. How we crave milk when we are teenagers or children, when our skeleton's still growing. So that is where we are right here. All right, storing calcium for us. The bones also produce our blood cells for us, all of the blood cells. We have a place in the bone marrow, myello is bone marrow. And in that area inside the bones is where we produce all of our blood cells. All right. So when somebody has a condition like leukemia, people think that's a condition of the blood, but technically it's a condition of the bone marrow. Yeah, they don't have enough white cells because their bone marrow is not producing them appropriately.
Mhm.
And we also store fat in our bones. Does that sound odd to you? That you have fat inside your bones, especially the long bones of the arms and legs. And that's one of the concerns about breaking your arm or your leg, especially a big bone like the thigh bone. You break that bone, and there's a chance that some of the fat inside the bone can get into your bloodstream and cause a fat embolism. Start blocking your lungs, your heart, or your lungs or your heart or your brain, and can cause strokes, heart attacks, and even death if fat gets into your bloodstream. If you remember from the digestive system last module, we mentioned that all fat has to be liquefied or emulsified, turned into oil before we circulate it around the body. Solid fat tends to block up things. So if you break a bone and some of that fat gets out into the bloodstream, it can cause a serious problem. And that's one case where somebody could break their leg and die from it. And y'all may have heard this before, seen it in a movie, or experienced it in your life. Is that if you suspect that somebody has a broken bones, you shouldn't move them, and that's the reason. One is that we have nerves and blood vessels running all along those bones, and if you move one of the broken ends, it could sever a nerve tract or rupture a blood vessel. But the other reason is that if that bone gets moved, and the fat gets a chance to leak out of there as well. So in first aid, we have a saying, splint it as it lies. In other words, however you find it, that's the way you splint it. Don't be trying to straighten out bones or joints and things like that. And because of the danger of severing an artery, a vein, or a nerve tract, or allowing fat to leak out into the system. All right. So our bones also store fat for us. All right, so we're going to start with continue into the types of bones we have in our body. Now, I don't follow the chapter very closely on this one. All the information is there, plus. So in your chapter, they don't talk about the types of bones. So I feel that that's important to talk about. So here we go. All right. We have long bones, your basic Fred Flintstone bone, the bones that make up our arms and legs. Those that typically look something like, writing with the wrong end. The cartoon version, the long bone. Let me pause for just a second because it's not open on here. I want to go, and y'all know I need to open my whiteboard. So first I have to find it. Well, first I need to put on my glasses so that I can see. This laptop is much smaller than what I'm used to right now. There it is. All right. Where did it open at? There it is, right there. Oh, okay, it's still opening. And let's go on and drag it over here. All right. So we'll let that keep opening. All right. So anyway, those are your basic long bone, the bones that make up your arms and legs. And in the condition of dwarfism, these are the bones that actually don't grow. So in the typical, or one of the types of dwarfism, their torso, their head, their pelvis are all the same size as everybody else's, but their long bones don't grow, and they end up with really short bones. And if we have long bones, then we probably also have short bones. The bones of the wrists, hands, ankles, feet, fingers, and toes are all short bones. They look the same in many cases, but in some cases they look the same, but they are short. And then we have flat bones. Our flat bones examples are the cranium. Now, I know the skull is curved in shape, but the bone in nature is flat. So if you take a flat bone and curve it, that's your skull bone. So the bones of the skull, the breastbone, center of the chest, our ribs, and our pelvis are all flat bones. And then we have irregular bones. These are bones that have different shapes based on their positioning. And irregular bones include the bones of our face and our vertebrae or backbones. They have a unique shape based on their location or position on the skeleton. So those are our types of bones: long, short, flat, and irregular. You might see a sample test question that says, which of the following is not one of the types of bones? Long bones, short bones, flat, and irregular bones. Now, the bones would be, our skeleton would be pretty difficult to manage if we didn't have joints between our bones. Movements would be like really, really restricted if we couldn't bend the elbow, for example. And that gives us types of joints because not all joints move the same. If you compare your elbow, for example, which moves in one plane or direction, to the shoulder, which moves in multiple planes or directions. That gives us different types of joints. And the first type is your freely movable joints. These are joints that aren't restricted in movement except by the type of joint. In other words, my elbow is a freely movable joint, and so is my shoulder, but they're different in that they move in different directions. And synovial joints are freely movable. These joints are encapsulated. They have a membrane in there that prevents friction as you move these joints freely through their range of motion. And let's take a look at a, wait a minute, now let's go back here. I want to go back here. All right. So when you look at a synovial joint, really, you see that the joint itself, oh, come on. Okay, thank you. That's because this laptop is running this whole thing. You know, we can expect it to run a little bit slower than what I use at work. All right. The two bones will come close together, but they won't touch each other. If these two edges were to touch, that would be quite painful. And later on, we'll be talking about conditions where they actually do touch. And that joint is encapsulated. There's a membrane that covers the entire joint all the way around. So if you were to cut open a person's knee, you wouldn't see the two bones. You'd see the capsule completely covering those. And if you cut through the capsule, the two bones are tucked away inside there. That capsule is called your synovial membrane. And it secretes a fluid that's an oily fluid that fills the spaces in here. Like the oil in a car engine. As the piston moves up and down through the cylinder, it has oil in there to keep it from rubbing and keep friction to a minimum. And that's what happens in your knee joint with your synovial fluid. The oil of our skeleton system, the oil of our skeleton. As long as you've got plenty of that oil in these joints, you're going to have nice, smooth movement. And that's when you are, 12, 13, 14, 15, 20, 21, unless you have engaged in sports or other activities that have damaged your skeleton. But typically, young kids, we just run all day long. Old folks, we're gonna start holding our knees after a little bit, and hips gonna get sore and all this mess because we damaged these joints over the years. And like I said, damage to the skeleton, unless you have surgery to repair it, is typically going to be lifelong. So the synovial membrane produces the fluid inside there that gives nice smooth movement as we move this joint. And that's a synovial joint. It's encapsulated with fluid inside that gives smooth movement at those joints. So bones don't rub together and you don't get any friction when you move your skeleton. Yeah. Now, some people over time, we'll get back to that one here in just a minute. I want to, no, we'll stay here. All right. So that's a synovial joint. And we were going to find two types of those. The two main types are your hinge joints and your ball and socket joints. A hinge joint is a joint that moves just in one plane, like the hinge of a door. Your elbows, your knees. Could you imagine if your elbows could move like your shoulders and your arm could just swing out to the side and all this mess? I know it looks like it does, but when I move my arm out to the side, I'm actually rotating the shoulder joint. The elbow joint stays in just that one plane. But could you imagine if that thing could just like move all the way around and what type of dance moves you'd see on the dance floor with people just like elbows just all over the freaking place. But they only move in one plane. Our fingers, our elbows, our knees, our toes are all hinge joints. They only move in one plane. As opposed to the ball and socket joint at our shoulders and hips, which gives us rotation. Now, in a ball and socket joint, just like the name implies, you'll see a bone that has a ball on it. And that ball will fit into a socket of an adjoining bone, like your hip bone, the ball and the socket. Now with this arrangement, this can rotate now completely on this ball and give you full rotation in all different planes of movement. Okay? So that is a ball and socket joint. So the two types of synovial, and it has the same synovial membrane encapsulating the entire joint in there, giving smooth movement as you rotate your hips or shoulders. So those are our two types of synovial joints, the hinge joints and the ball and socket joint. Ball and socket you find at your shoulders and hips. And there's a good test question for you. Hinge joints and ball and socket joints are example of synovial joints. Now, the next type of joint is called a symphysis joint. This is a joint that only moves a little bit and only under certain circumstances. And I think when I did this last time, I just went online and pulled one up. So let's do that. Let's delete that. I can close that. Let's go to here and I want to see the pubis symphysis. And that's a joint right there. With the cartilage, the blue is actually cartilage. This is the joint, this bone right here, and that bone right there. Now this joint, since it does have cartilage, so it is a joint, and it only moves a little bit, and only under certain circumstances. Can anybody think of the circumstance where this joint would be required to move?
Stretching.
When you're having a baby.
Childbirth.
Pregnancy.
Childbirth.
Mm.
See, this is the birth canal right here.
What's wrong? Is it stretching?
Yeah, the baby's head's got to go through there. And y'all seen them babies and big old heads they be born with. And this thing has to sometimes, or many cases, most cases, stretch just a little bit to get the baby's head through there. And that's part of the pain of childbirth, is the pubis symphysis. So it's a joint that moves just a little bit and only under certain circumstances. A symphysis joint. Now, it doesn't require synovial membrane because it doesn't move near enough to require that type of protection. So a symphysis joint is a slightly movable joint. And that's in it. There it is right there. The pubis symphysis is the best example of that. Now, a suture joint. This joint is immovable. It doesn't move at all. Once the two bones knit together, there's no more movement allowed between them. And the best example of a suture joint is the sutures of the skull. The cranial sutures. And I know that other one was a better picture. Here's this one. All right. With the when the baby's born, remember that the brain is not fully grown in there. It still has some growing to do. And that's why these skull bones are not knit together to allow the baby's brain to grow in there. And bone will fill the space, continue until the skull is big enough to house the baby's fully grown brain. And also, when this baby's head comes through that birth canal, you're going to be thankful for these sutures. They allow the skull to collapse just a little bit and squeeze its way through, okay, rather than trying to just push this big old rock head through there. So it comes down and the baby's head squeezes through there. And that's why you might, did anybody have a baby that was cone head when they were born? Baby had a cone shaped head and the doctor told you to just massage it and the bones would fall back into place. That's the baby's head squeezing, trying to get through there. You may be born with this big old cone head baby. And then you just massage it, gently, and everything will spread back out eventually. So these are the sutures of the skull. The term we use for suture, the word is fontanelle. There's a good one. So these are, and you see the word right there, the fontanelles. Those are what we call the soft spots, anterior and posterior fontanelle. Now, in your textbook, they only show one of these. In the picture of the skull, just like this one, they don't show the posterior fontanelle. And they show that this is a solid bone rather than a small, tiny suture down through the middle of it. Okay. But these will eventually knit together, and then the baby skull will be solid. Does anybody know how long it takes for these to actually knit? Any idea what age before your, first of all, what age before the soft spots are hard to the touch? About what age?
1.
Between 1.5 years old. And now, how old are you before your sutures are completely knit together?
2.
About 18.
What the hell?
Yeah, so some of y'all might still have soft spots. Anyway, yeah, babies. Anyway, so and once they grow together, that's it. There's no more movement between them. Now, sometimes, guys, this is so. Have you ever heard this? That if a baby's soft spot sinks in, you're supposed to push on the roof of their mouth.
Yeah.
Y'all heard that? Yeah, yeah.
Old wives' tale.
I get that so much, y'all. Now, first of all, why does the suture sink? Because you hold the baby upright. And gravity pulls down on everything and the suture sinks in. So how do you get it to pop back up?
My mom said something about turning them upside down, hit them in the bottom of the feet or something. I was like, well, I'm not doing that to my child. I was like, that sounds crazy.
Lay them flat on their back. As soon as they go flat on the back, gravity pulls and everything goes like this now, and the soft spot pops back up. Uh, the other one was you lay them down on the back and you push on the roof of their mouth. Just lying them down is enough to do it. And would it pop back up if you turn them upside down? Yep. Because remember now you turn them over, grab it, and it pops right. So you have to tap on their feet. You just turn them upside down. I wouldn't do that because you can do the same thing just by laying the baby flat on their back, and it will pop back up. All right. So anyway, but don't be pushing on it and things like that. At about a year to a year and a half, this thing will be solid to the touch, and it still means that the skull is still fragile, but it's not as fragile as it was at new birth. So those are the sutures of the skull. You see, they do have names: the coronal and the topic, and then the sagittal suture. Those names sounded familiar to you? Coronal, front, sagittal, splits into left and right parts.
Yes.
Coronal separates into front and back parts. The coronal suture, the sagittal suture. So you're saying these terms will repeat themselves all throughout your lessons. And then the lambdoid suture towards the back. Now, and those are the suture joints. And the soft spots between the sutures, the one at the front and the one at the back, those are called fontanelle. And you know what, I think I want to go on and enter that. The fontanelles or soft spots. All right, so those are our three types of joints. Synovial joints, they're freely movable. The symphysis joint, which is slightly movable. And then the suture joint, which is an immovable joint. All right. All right. You know what? I know how y'all be writing on my stuff. You open it in the email. You just double click on it and it opens it up. Okay? And that leaves it for anybody to edit. I haven't figured out how to turn that off yet, but I will. What you need to be doing is downloading this, then opening it, then you can write all over it. But if you just double click the email, then you're opening the same one that I'm opening in. Okay? And
Well, I can write on yours without opening it because I use the code and stuff. But what I do, if I tap on my screen, I see a pencil. And if I touch that pencil, then I can write on your screen.
well, don't be
I
doing
don't do
that.
it, but
Yeah, but you figured it out.
yeah.
I don't do it, but I know how to do it. If I ever want to do it, I can do it anyway. So anyway, that is joints and the types of joints we have. Now, joints are also incorporate the stuff that y'all have heard of as cartilage. So how does cartilage work? Think of it like a two joint or two bones that come together, but you see how they're nice and tight, but they don't actually touch each other. That's the cartilage in between them. So the joint is tight, but the bones don't hit each other. That would be painful if they did. So that's what cartilage does. It gives us a shock absorber between the bones so that our joints can stay nice and tight, and they can absorb some shock without the bones actually hitting each other. So there's a shock absorber between joints. And the word part for cartilage is chondro. And there's a good use of that term, chondromalacia. The softening of the cartilage in your joints. And as the cartilage gets softer, the bones come closer and closer to touching. Eventually, you'll reach the point where your knees just hurt after walking for a while, okay? Because the cartilage is getting thinner in there. And after a while, the compression allows the bones to actually just, interact a little bit. So you've been walking on these knees for a couple of hours. Eventually, that cartilage wears more away, and now that joint hurts all the time because the bones are in direct contact with each other. That's somebody we're going to consider for a knee replacement, because once cartilage is damaged, it doesn't repair itself. Right? So chondromalacia is softening of the cartilage in a joint. We're all going to suffer some of it over time. The most common form of arthritis is called osteoarthritis, which is just wear and tear on your joints over years. So we're all going to have some of this as we get older. And believe it or not, if you are a runner, a jogger, those type activities, it's going to progress in you faster. You would think that that would keep your joints healthy, but running actually does put a lot of pressure and damage on joints. So if you ask me, the best way to stay fit is to walk, not putting near as much grounding and pounding on your joints. Now, if you are a person who started in track and field when you were like 6 years old and you've been running your entire life, then you may not have or suffer some of this as dramatically as somebody who decides in their 30s they're going to start running. Imagine the way you are right now if you're not a runner and you just decide, okay, tomorrow I'm going to start running. No, you're not. You're going to run about a block and your joints are going to be like, ooh, ooh. It's going to take some time. And most people just don't have that type of discipline if they haven't been runners for their entire life. Somebody who just enjoys running. If you don't enjoy it and you say, well, I'm just going to run to be healthy, you're probably not. Those people you see out there doing it, they're actually having fun. They're enjoying running down the street like that. Unless you have that mindset, you're not going to run like they do. I promise you. Because
I had a trainer tell me too, but he used to box. He told me he would always tell me not to run on the sidewalk. He'd be like, run on the grass because of your knees and this and that. I'm like, okay.
Okay, how about just not run?
Yeah.
How about find another way? You can bike. How about that?
Yeah.
You can walk.
Mm-hmm.
I mean, walk for real, not just stroll like I do. When we go for walks, my wife and I, we're going to start walking every evening. All right. And I just kind of stroll, y'all. Half the time I got a cigarette in my hand. Stroll, you know. I am not running anywhere. So the other day, my dog got into it with some dog in the front yard, man. And they're running. I'm trying to catch him. I'm like, oh, hell with this shit. I just grabbed something and threw it at the other dog. I'm not chasing you. And I don't run, man. Are you kidding me? I'm just going to have to get the next bus. I'm sorry. See fools out here running, trying to get on a bus. You know what? I'm going to leave 2 hours before I have to get there just so I don't have to run for the freaking bus because I'm not running anywhere. So anyway, biking. I just told my wife I want to buy one of those sit down bike things, you know, with all the meters and all that on the front so you can sit down and pedal because I don't want to be up on the trying to ride a stupid bike. And that's kind of dumb because every year I watch the Tour de France, y'all, every year. And this year was obviously canceled because of the COVID. They started on the 4th of July. So I watched the, matter of fact, it'd be going right now. I watch that every year, but I am not a biker. I just like to watch the spectacle of the thing. All right. So anyway, down. Chondromalacia is the softening of the joints. Now, arthritis, the one I just mentioned was osteoarthritis. Degenerative joint disease, or DJD, I have that. And it's happening. I'm feeling it every day, y'all, in my hips, in my knees, but primarily in my spinal column. Okay? The amount of cartilage in the spinal column is, there's quite a lot of it. So between each of our spinal bones or vertebrae, there's a pad of cartilage between each one of those. And even that's breaking down when you have DJD, degenerative joint disease. The joints are just breaking down.
Say a spinal fracture, does that happen to the cartilage as well, or to the?
Yeah, it can tear. Yeah, it can turn. It can tear the cartilage. Or it can happen just inside the bone itself. So if you have one bone or one vertebrae, your fracture can happen in here, or the fracture can happen across here and interact with the cartilage as well. Okay. The bad news is the bone will grow back together. The cartilage, once it's damaged, is damaged. It won't repair itself. All right, so you see, then also rheumatoid arthritis. Now, rheumatoid arthritis is autoimmune. I don't know if we've had a chance to use that term in class yet. Auto means self. Immune means it refers to the immune system. So in this disease, or all these types of diseases that are autoimmune, it's when your immune system is attacking your own tissues because it doesn't recognize it as part of your body. For some reason, the ID badge or marker on that tissue has become unrecognizable by your immune system. And the immune system starts to attack that tissue as if it doesn't belong to you. Other examples of autoimmune disorders are lupus, multiple sclerosis, the skin disease, psoriasis. These are all autoimmune, and so is rheumatoid arthritis. Now, what's happening in rheumatoid arthritis is their immune system is attacking and destroying, and let's make these finger bones, okay? The bones of your hand right here, and then this is your finger. And the same arrangement, the synovial membrane around it, and the fluid inside. And then you'd have 2, 3, 4, 5 finger, hand, and then the rest of your finger bones. So when you have rheumatoid arthritis, what's happening is your immune system is attacking your synovial membrane and damaging it. And as a result, it starts to swell up. So you have these nodules that appear over your knuckles. But not only that, with the swelling, it's not only on the outside like that, but it swells inside the capsule. And that causes your finger bones to get pushed out of position. So this is what your joint ends up looking like. Yeah. And that's why this person's hands look like that. You see the nodules over the joints? All up here. You see the joints being shifted out of position? And it just can get just worse and worse and worse. This is actually not the worst rheumatoid arthritis I've seen, but it's their immune system doing it to them. So the only way to correct that is to turn off their immune system. And then that's going to open you up to all types of other infections. And that's one of the conditions in which is an issue for COVID infection today. Somebody who has an autoimmune disorder. So all those people out there who have lupus and so on, they're at a greater risk of dying from the disease. And my sister contracted COVID. She's recovered, but she has lupus. So we were really worried for a period of time because, and actually she never had to really go to the hospital. And that's one thing about my people, y'all. We do have strong immune systems. I'm just not worried about, contracting the virus and dying from it because my immune system is just that strong. I usually don't get colds and flus at all. I never get colds or flus. Not saying that I don't contract them, but when I do, my immune system destroys them so quickly they don't get a chance to make me sick. But with me being a smoker and all that, I really don't want to be messing around with this COVID-19, even if I do have a strong immune system, because I'll be one of the ones laying up in the damn hospital on a ventilator. All
Mr.
right.
Mahone,
Yes.
my husband has he has the rheumatoid arthritis and he has psoriasis, and we both had COVID, and his bones, joints, everything ached on him. His was way more severe, I felt like, than what I was, and we had it at the same time.
Mhm.
And now that we've recovered, that was like in March. Now that we've recovered, it's not any better. Like his bones still ache. Like everything still aches. Like he's going to the doctor today at 2:30 because like it hurts all the time.
Okay.
So is it like once the swelling goes down, it's not going to get any better, or?
You may have had some cartilage damage from the swelling. And
From the swelling.
I want to caution y'all as well now, not to be an alarmist or anything, but that one lady who was in the news for a while, she was in her 20s. She had COVID. She recovered from it. And then a couple months later, her kidney shut down. And it was all due to the COVID-19. So just because you've gone in the hospital or you've recovered at home or whatever, it doesn't mean that you are out of the woods, if you will. It was a couple months later, and this lady's kidney shut down, and she was in her 20s.
Well, I
So
saw that on the news the other day. Some lady too, she recovered and then she had like a heart attack or stroke or something happened. She just died. I'm like, oh my God.
because it just damages the organs in the process of getting through the infection. So no, I do not want this stuff, y'all. I'm sorry. And again, I don't want to be an alarmist, but in the joints, you'll probably be arthritic from now on.
That
Well,
sucks.
I don't know. My testing still didn't come back from before, like a couple weeks ago when I got sick. But my back, oh, I was aching really bad on my back, and they gave me like ibuprofen and stuff, but I don't ache anymore.
Well,
But I
remember,
had the pneumonia.
we've had a lot of high pressure days lately. Not high pressure, high pressure, high atmospheric pressure.
Yeah.
And that puts pressures on our joints, and it makes our joints ache sometimes as well. So we've had a few days of high pressure that could be the answer to people with all the joint aches and things like that. My hip is really bugging me right now. Yeah. Because again, there are some clouds. It's not what I guess it's what you could call partial cloudy. Yeah, I can expect some of that on these days. All right, so that's rheumatoid arthritis. And if you are really unlucky, juvenile rheumatoid arthritis. These are kids who have this as children. And the same thing is happening to their joints. Yeah. I've had some of these clients in occupational therapy with JRA, and those kids just want to play, y'all, but their hands hurt so bad. So one way that we found effective was to take a couple of heating pads. Remember, heat for pain, cold for pain, but we take a couple of heating pads and we put their hand, or heat for swelling of the joints, and we would put their hands between the two heating pads and give them the controller for the video game, and they could play, video games for a little while. But eventually, their hands just become too sore. About an hour or so, and they're pretty much done. But remember that in therapy, we use video games quite a bit to aid in our therapy, especially hand therapy. So anyway, juvenile rheumatoid arthritis is when this is happening to children for the same reason. Their immune system is attacking and destroying the tissue. All right, so those are forms of arthritis. The one that most of us are going to have in our life is this one right here. Osteoarthritis, the wear and tear arthritis. All right. Now we did mention cartilage, that pad of protection that keeps the bones from knocking together, but also lets our joints come nice and close together. Another word that we should pay attention to here is articular. When a joint is articulated, that means that it comes together exactly like it's supposed to. And articular cartilage helps to maintain that that arrangement in the joint. If a doctor refers to a person's joint as being disarticulated, it's the same as being dislocated. The joint is not aligned like it should be. So articular cartilage also helps to keep the joint aligned like it should be and keep it nice and tight together without the bones actually hitting each other. So it helps the articulation of the joint. All right. So examples of a good example of cartilage in the body is the cartilage of the knee joint. Since the knee is one of our major weight-bearing joints, there's only two joints that bear more weight than the knees. Anybody know what they are?
Your hips, maybe?
No, the hips are above the knees.
Oh,
Your ankle.
Ankles, yes. Okay. The ankles bear the full weight of the body, including the weight of the lower leg. The knee joint bears all the weight up to the lower leg. So it's one of our major weight-bearing joints, and it has a large pad of cartilage in there. Y'all may have heard of this before. It's called the meniscus. And if you hear about somebody who tears their meniscus, that stuff's not going to repair on its own. They're going to have a knee surgery to go in there and repair that. But also remember that this entire joint is encapsulated. So if they want to get inside there to repair that meniscus, they're going to damage the synovial membrane just getting through there. This is why we don't want to do anything in a person's joint unless we absolutely have to. We're going to damage the joint just to get in there and repair it. And they use scopes and small instruments through, but it's still going to be poking holes in the synovial membrane. And every place you do, scar tissue is going to occur right there, and that membrane won't produce the fluid that it's supposed to. So having joint surgery on a joint, you can look forward to having issues with that joint from now on. Things like my knee hurts whenever it rains, stuff like that. There was one lady, she was a volleyball player, one of the beach volleyball players. And I was just watching the match one day, and they were talking about this lady has had 9 surgeries on her shoulder. I can't imagine what those shoulders are going to feel like by the time she's 45, 50 years old. She won't be playing volleyball, I can tell you that much. But she's one of the gold medal winners, gets all the endorsements and stuff, so I'm sure she'll be set by then. But this is why you always see, well, why is so-and-so retiring from football? Because so-and-so is old, man. You can't take those bumps and bruises like that anymore. So-and-so is retiring from basketball. Yeah, jumping up and down and coming down on your knees that much and your ankles, that cartilage is going to wear down in there. There was this, well, when I was stationed over at Fort Sam Houston, I was an Air Force guy, but I was stationed with an Army unit. So we had the opportunity to do things that people in the Air Force don't typically get a chance to do, like go to air assault school, the helicopter, swinging out of the helicopter, and jump school. And I had done air assault school. That was fun, the helicopters, and I would love that kind of stuff. But then they said, so Mahone, you want to go to jump school? Hell no. Jumping out of airplanes and letting a piece of cloth determine whether you survive or not. No, I think I'll skip that one. But anyway, people, and don't fall for what the Army does. You see, the Army has these big recruiting rallies and demo shows to try and get people to join the Army. And they have this parachute demo team called the Golden Knights. And you know, you can see them. They jump out the airplane at whatever altitude. You can see them up there, and they've got smoke coming off the heel. This little smoke machine on their boot, so it's shooting out smoke, and you can see the smoke and the red, white, and blue, and they're all following each other, and it's really cool. Like 10 of them coming down, all on their parachutes, and they're da 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 da. And then when they get down to the ground, there's a big X on the ground. And they come to that X, y'all, and they've got these toggles on the parachute that they pull straight down like that. And the parachute literally just boom, just stops and lowers them to the ground. And they all hit the ground walking, one right behind the other, each one of them landing right on that X. Boom, boom. And then they turn around and they start rolling up there, and it looks so freaking cool. And everybody's clapping, yeah, I want to join the Army, yeah, jump out of airplanes. Okay, if you join the Army and jump out of airplanes, you are not going to get that parachute, the one that they have. That thing costs about between $5,000 and $7,000. They're not going to give one of those to everybody. You're going to get the other one, the one that doesn't have the toggle part. Okay, and you just kind of hold on like this, and you go wherever that thing takes you. Now, see, those dudes, they can guide that thing and do little, y'all seen the parachute stunt people. They can do all of that. The parachute that you get, you hold the little straps right here, and wherever it goes, you go with it. And one dude actually landed in the zoo on a practice jump up on the East Coast, where they do all that kind of stuff at Fort Bragg. And the guy actually landed in the zoo. Now, he didn't land, he landed on one of the paths. He didn't land in any of the exhibit things. But can you imagine that dude coming down going, is that the zoo? And you imagine yourself landing in the lion pit or some shit. But he landed on one of the paths, so he was okay. One dude landed in the schoolyard. And these are people who, when they jump and it's really windy and the wind takes over that parachute, it takes you wherever you go. Now, when they do hit the ground, they don't hit softly. They hit what's called a 3-point landing, ankles to hips to shoulders. And if you don't roll into it just right, you end up breaking a bone. So when they launch paratroopers like that, they do what we call airline booking. If they need 1,000 troops on the ground, they're gonna launch 1,100 because they expect a certain number of them to break bones and things like that when they hit the ground. So the reason I mention that is that I knew a guy in the Army, retired from the Army. Yeah, I saw him over at the VA hospital. We're just talking, and he was like, "Yeah, I got a double knee replacement." Double knee replacement? How old are you, dude? I'm 36. A double knee replacement. And I said, let me guess. You are a paratrooper. Yep. Like, oh yeah, I'm really proud. I'm a paratrooper. Yeah, double knee replacement at 35, 36 years old. That's ridiculous. But it's not just paratroopers. Have y'all seen the Army truck, the one that kind of looks like a covered wagon, got the green canvas over the back, the troop carrier? They call them deuce and a halves. Have y'all seen how high the deck of that truck is off the ground? Well, let me just say that when I would be talking to somebody in the truck, you'd be leaning on the deck like this. That's how tall the deck is. And now imagine 20 years of jumping from my shoulder height to the ground. Boom, boom. And can you talk to them young troops into not jumping out that truck? Because there's a step there. They could turn around, put their foot down and step down. But try to tell a 19-year-old that. And what they end up doing, jumping off the back. But then you see the E6, E7, the sergeant, walk to the back, turn around, step down on that step and step down out that truck. Be like, Sarge, you getting old? Yeah. If I would have jumped that same height out of that truck, I'd get a shock of pain through my freaking knees. And they're going to learn eventually too. Remember, hard head, make a soft ass. We tell them, don't be jumping out the damn truck. Now, what about dock workers? Somebody who works the back dock of a warehouse or something like that. There are steps down there for you to go up and down the height of the dock. But no, you get them there 18, 19 years old, they're jumping down, I'm good, Yeah, you're going to be damaging those knees. So people who tear or the meniscus or they damage the meniscus in some way, they might be headed towards a knee replacement. Now, we might get through a little bit of time injecting the knee, putting more fluid in there to kind of take up the slack from the damage to the cartilage. But eventually, they're going to need a knee replacement. And that is if they can't go in, if they can't go in and surgically repair the meniscus. They do that sometimes. But if they can't do that, then yeah, you're headed for a knee replacement. So that's what we mean when somebody says they have to have their knee injected. They're putting more fluid into the knee to accommodate for the lack of cartilage in there. And hopefully you get enough fluid in there where they can just float over this part. So that's what we're doing when we're injecting somebody's knee. So the meniscus is the large pad of cartilage in the knee joint. All right. So right now, I'm going to go ahead and write down who's here because I was smart enough to bring my book with me. All right. So I don't see oh, there's Elof. Nicole, you here? Yes, she is. And Delia is here. Michelle Chestnut, you here? There you are. Christopher is here. Cheryl is here. Chloe, do I see you? Chloe Eddingfield, yep. And then Rebecca. Rebecca, there you are. What about Destiny Garcia? Destiny, you here?
Yes, I'm here.
Okay. And Cassie? Yep. How about Elena Guzman?
I'm here.
Okay. And Isaac, are you here? Isaac. Okay. Danielle Lopez, there you are.
I'm here, sir.
I see you. Maricela Lopez,
I'm here.
okay. And Tatiana. Tatiana,
I'm here.
okay. About Maria Martinez. Maria Martinez. Going once, going twice.
Hold up,
She's here.
she just messaged something.
Yeah, she's here.
Okay, thank you. Monica is here. Chloe McDaniel, you here? Chloe. Who's doing stuff on my computer? Oh, I'm putting the book on top of the stupid thing. Never mind.
Chloe was here and she's put in the chat that she was having trouble getting back in once you got home.
Okay. Jose is here. Wendy?
Yes, I'm
Okay,
here.
gotcha. About Lionadra? Christy is here. Sarah? Do I see Sarah? There you are. Carissa is here. And finally, Esther. Esther.
I'm
One
here.
more time. Oh, okay, I see you. All right. So the people I have not here are Isaac, one more time, and Lionadra, one more time. Okay, so let's go ahead and take a 15-minute break. It's 11:45. Come back on the hour. Let me send this email to let them know who is not here today, and we'll continue on the hour at 10 o'clock. All right. Okay, now I'm back. All right. So we have made it up through the types of joints and cartilage in the joints. We talked a little bit about damage to the joints. And you young people, let me say this, protect your joints now. Because by the time you're my age, it's going to be a little late. My shoulders don't move without aching. And like I said, I got a problem with my hips today and all that, but I do have a DJD. So it might not be dramatic as you get older, but keep your skeleton healthy. My wife has talked about I need to get calcium supplements and all that. There are no problems with my bones. It's the joints that are breaking down. And calcium supplements don't do a whole lot for joint issues, breakdown in cartilage and things like that. I've got a feeling they're probably going to be talking to me in a few years about knee replacement or hip replacement and all this kind of mess. And I don't know if I'm going to go through that. Probably just going and buy myself one of those electric chairs, which I'm thinking about doing right now. Told my wife, we went to the flea market this weekend, told my wife it's about time for me to get an electric chair, right? So that I can cruise around the flea market and bump into your feet and that kind of stuff. Get out my way, Holmes. Anyway, so where is everybody? Did somebody get kicked out? All right.
No, there's still
Hey,
23.
yeah, I may seem a little distracted as I keep looking to see if when Alan shows up. He's supposed to be here at 11 o'clock, but he said he'd be here a little bit early. So I'm going to keep looking for that as I talk. So anyway, the next thing we want to talk about then are the ligaments and what they do. Ligaments attach bone to bone. And once a ligament is stretched, it doesn't go back down to shape or size. So if you dislocate your shoulder, what you're doing is stretching the ligament that holds the shoulder joint in place. Now, once we get the joint put back in place, that ligament is permanently stretched. So now you can dislocate your shoulder easier the next time, unless they go in and do surgery, cut out a section of the ligament and pull it back together and stitch it. When I talk about ligaments, I like to mention the ligaments of the knee joint, because if you watch any type of sports, you probably have heard of these before. There should be another L in here. Both of those. Right. You probably heard of these ligaments before. This is the person's right knee. The reason that I know that is because the lateral ligament is right there.
So MCL, ACL, that's what you're talking about, right?
Yes,
The
all the ligaments of the knee. This is the lateral ligament right there, because this is the lateral bone. So as you know what the skeleton looks like, you'll be able to determine by position of the things around it which knee joint this is. So this is the right joint of the knee. And that makes this ligament right here. See it coming down from this bone, attaching it to the lower leg bone right there. Okay. And that's your lateral collateral ligament, the LCL. Lateral to the side, lateral collateral ligament. And that would make this one over here coming down from this bone and attaching it to the lower bone out there as your MCL, because it's on the medial side towards the middle. So the LCL, the MCL. And then these two ligaments that cross in here, one right there and one crosses in the back there. These help to give the knee lateral stability. Remember, the knee joint is only supposed to move in one direction. If it moves to the side, are y'all seeing, where am I on here? Are y'all seeing me? Oh, I put
Yes.
I see
I
it.
put
Now
myself.
you went off.
I was on the other screen over there. But anyway, the knee joint moves like one direction, but if it moves sideways, that's going to be an issue. So these give the knee lateral stability, so they don't move too far side to side. And those are your anterior cruciate, since they cross. They're cruciate. The one in the front is the anterior. The one in the back is the posterior, the ACL and the PCL. You hear about these in sports all the time. So-and-so pulled their ACL. They tore their MCL. They're talking about the ligaments of the knee. LCL, MCL, ACL, and PCL. Okay. So that's what a ligament does. It attaches bones to other bones, and it keeps our skeleton together. Now, since the ligaments are soft tissue, or what we call connective tissue, they connect the joints, or they connect things in our body. And if you've heard of lupus before, you know that lupus affects connective tissue in the body. And that's why people with lupus see so many different doctors. We have connective tissue all over the body. And if you know somebody who's had lupus or has lupus, you'll know that they'll see several different doctors in their treatment, because lupus can affect any part of the body, including the joints, because our ligaments are connective tissue as well. Remember, lupus is that autoimmune disorder where their immune system is attacking and destroying their own tissues, and lupus is connective tissue that it's attacking, including the ligaments. So my sister is now, she's a year older or 2 years older than me, and she's walking with a cane because the joints are just being attacked by the lupus.
Tony Braxton has that.
Who?
Tony Braxton.
Oh, poor thing, no more dancing on stage, like
Yeah, that's why we don't
all
see
the
her.
little dances and stuff. Anyway. You'll start seeing her standing and singing in one place now, rather than dancing all over the stage.
Yep.
Y'all remember? I know y'all remember Prince. Did y'all know that in the later days he was walking with a cane?
Mm-mm.
Yeah, his joints were horribly damaged.
Yeah, he was brittle.
One of the reasons was that he wore those high heels.
Oh yeah.
Yeah, and you're standing up on top of a piano, and you're jumping off the piano down onto the stage in those high heels, and then you're splitting and doing spinning and doing a split and all this mess. And in his later days, he was in serious pain. And that's one of the reasons they think that led to his death was the fact that he was overusing pain meds. He was addicted to pain meds. So as we get older, guys, our joints are just going to give up on us and prevent us from doing all those things we did as a young person. So protect your joints today. All that jumping and learn how to shoot a basketball without jumping up in the air. That's probably the most useless part of shooting a basketball. Have you ever seen the professional pros? When they're shooting a three-pointer, their feet don't leave the floor. When they're shooting a rebound or a extra point, they don't jump in the air. They plant their feet and they shoot. But if you go down to your local park and you're watching people out there, you see folks at the three-point jumping up in the air and shooting. So just protect your joints over the years. And again, probably the biggest thing to damage your joints today, commonly in people, is running. We don't run near as much as our ancestors did, but when you go someplace like Nigeria, where people just run all the time, and that's why they're always winning the Boston Marathon and that type of stuff, because they're just a culture of running and runners. Look at this dog coming in my yard. Anyway, they're just a culture of runners. So when they run like that all your life, then yeah, your skeletal system will maintain. But if you are, my age and you're trying to start running, it's not going to work out for you. So anyway, those are ligaments holding your joints together for you. And it's always funny to see on TV or in a movie or silly movie or something like that, where you see a skeleton and the skeleton is hanging, but all the bones are still intact. Yeah. When the soft tissue in your body decomposes, the ligaments will decompose as well, and the skeleton will fall apart. So you won't ever see a skeleton that you could just take from a person. They die and then you hang their skeleton up on the wall. It doesn't work that way. It'd just be a pile of bones. The ligaments hold them together. All right. And then some landmarks of bones that I want to mention is the first one you see illustrated or colored in green right there. This is called a process. A process is a part of a bone that sticks out for ligaments or tendons to attach to it. And the one you're seeing right here is called the mastoid process. Yesterday, we mentioned a muscle that went from the sternum across the clavicle and it attached into the back of the skull. That's the sternocleidomastoid. And this is where that muscle attaches into the mastoid bone. So the tendon from that muscle comes down and then it cuts across your chest and attaches to your sternum. So this part sticks out just so the sternocleidomastoid can attach to the skull. Yeah. So a part of a bone that sticks out for ligaments or tendons to attach. If you've ever taken a CPR class, then there's a ligament that you might be familiar with called a process called your xiphoid process. And it's the little purple part right there. This is the part when you're doing CPR on a person and you're pressing on their chest, you want to try and make sure you don't press down too low. If you put your hands down here where I'm circling and you're pushing on their chest, you're liable to break this little process right there. It's where the ligament or the tendons from the abdominal muscles come up and attach to the rib cage. If you break that process and it flips backwards, it could lacerate their liver, which sits right behind here, right behind the ribs. So that's another example of a process, a part that sticks out for tendons, in this case, the tendons of coming up from the abdominal muscles, or ligaments to attach to the skeletal system or to bones, a process. I also want to show this image of a, doggone it. Oh, why am I not thinking of this term? One of the swimmers had this in the last Olympics, Ryan Lochte. I remember that. Why am I not remembering the name of the condition? Because they made a big deal about it in the Olympics. Everybody writing in, what is that? See that dip in the middle of his chest right there? See, everybody kept sending in emails during the Olympics asking, what is that? Why is his chest dipped in like that? He has, doggone it, pectus excavatum. Doggone it. Why I couldn't think of that. Pectus excavatum. It's where the xiphoid process is not angled correctly. And as a result, they end up with that dip in the middle of their chest like that. I want to turn this off. I want to highlight this. Oh, come on. Anyway, doggone it. That shouldn't be red right there. Is all I'm trying to do is change the font right there. I don't want to draw. I want to home. And it's still doing it. Draw, turn this off. Thank you. Jeez. Really? Oh, man. This is what I get for using two different versions of PowerPoint at the same time.
Hit that arrow that curves, Mr. Mahone.
Huh?
Go
Where?
up. Right there, go up. Hold on, I can't see it. Right there, yeah, click that.
That's undo.
Just keep, yeah, just do up, just redo it. There you go.
I don't want to do it because now the pen doesn't work. Yeah, see what I mean? That's what I get for using two different versions of PowerPoint at the same time. I have to go back to draw and the pen still doesn't work. So I don't want to draw with touch. I want to draw with select. All right, finally. All right, so anyway, that's pectus excavatum. I want to find a better picture since I know what I'm looking for now word-wise. And you can see that it can get pretty dramatic with the dip in the middle, in the center of the chest like that. They don't do anything about it unless there are major issues with the person's functioning. Other than that, they just leave it. Okay. And you see that these are pretty grown guys and nothing's been done to correct it in them. So don't be surprised if you see you're doing an EKG on somebody and you see a dip in the center of their chest like that. It's not uncommon, but it's not common either, but you can expect to see it in your career. Pectus excavatum. Okay, so that's a process, a part of a bone that sticks out for ligaments and tendons to attach. And obviously you see that that's in red. Okay, another landmark in bones is a foramen. It's how that's pronounced. Foramen. Somebody might say foramen, but I learned it as foramen. It's a hole in the bone for blood vessels and nerves to pass through. And you see the foramen magnum at the base of the skull. And this is the hole that the spinal cord comes through. With the brain inside the skull, the spinal cord comes down through that hole and down the back of the body. And that's why if you have meningitis, remember the meninges wrap around your spinal cord. So if you put your chin to your chest, if your meninges are swollen, when you put your chin to your chest, that's going to hurt. Take a look at it this way. You have the bone with the spinal cord coming through. If you put your chin to your chest, you see what's happening? you are squeezing the meninges if they're swollen. So that's why a classic sign of meningitis is to have the person put their chin to their chest. If they get pain at the back of their neck, then they're actually squeezing the spinal cord when they pull their head forward like that. And the foramen magnum is what actually killed, if anybody watches or has followed NASCAR at all, Dale Earnhardt, when he hit the wall at about 100 miles an hour. His head snapped forward so violently that the foramen magnum cut off the spinal cord. Just boom, just cut it off completely. And he evidently, they say he died instantly. So that is what a foramen is, a hole in a bone for blood vessels that nerves through. We actually have nerves that come out at our face, about two tiny. Hey guys, try to remember to mute your microphones when you're doing stuff. But there are two holes right here in the base of our skull, our mandible, that allows nerves to come out and service our chin at the tip right there. So a hole in a bone for blood vessels and nerves to pass through is a foramen. And a little bit about our bone marrow, not too much here, because we're going to talk about the blood cells, obviously, when we do the blood. But down the length of our bone, we find the marrow cavity. And that tissue in there produces blood cells for us. So let's take a look at the whiteboard real quick. And you'll see a bone. And we're going to call this a kid's bone, or somebody who hasn't finished going through puberty yet. They're going to have bone marrow in the ends of the bones. Somebody stop drawing on my slides. Down the long shaft, and then in the other end. So all of that is red bone marrow making blood cells. But now, remember that rule: if you don't use it, you lose it. Once you are progressed through puberty, you've produced all of the red blood, or all the blood cells your body actually needs. All the white blood cells that your body actually needs have already been produced now. So this part of the bone marrow stops producing blood cells, and instead it converts into yellow bone marrow. I don't have a yellow pen, so I'll use that. And yellow bone marrow, which stores fat. So red bone marrow produces blood cells, yellow bone marrow stores fat. So as adults, we still have to produce a bunch of red blood cells. So those are going to be produced in the ends of the bones. The long shaft is going to convert to yellow bone marrow, and from now on will store fat. Right. So when we need to take bone marrow from somebody to transplant into another person, y'all have heard of bone marrow transplants, we're not going to go into their long bones, because that would require us to go into their joints. Remember, I said we don't do that if we don't have to. In adults, you're not going to get any bone marrow from their long shaft, not the kind that we need, because this is all fat storage. So we don't take bone marrow donations from long bones, because that will require us going into their joints. Instead, when we want to take bone marrow from somebody, we're going to take it from the large flat bone. We're going to go into their hip, the largest flat bone they have. And down in that hip, you see them sticking a needle down in there, and they're going to pull bone marrow out of there. Prep it however they need to do, and then transplant that into the other person. They say it doesn't hurt, but the people who say it doesn't hurt are the people who's trying to talk you into donating. So I don't know if I would trust them or not. Okay. And they'll stand, oh, it doesn't hurt. Well, yeah, because you want me to donate. It's like the doctor who told me the cystoscopy wouldn't hurt. Cystoscopy is when they take a scope about the diameter of a pencil and they stick that down your urethra all the way up into your bladder. Doc's like, oh, it doesn't hurt. That shit hurt. Okay. So, but the lady will come over and tell you all the time when she does the blood and tissue center comes over to the school all the time. Oh, bone marrow transplants don't hurt. I don't know. I've never had one. I've never donated bone marrow. But now there's also the idea of the autologous transplant. Now, what that is when somebody has chemotherapy or radiation therapy. One of the iatrogenic effects of giving you radiation treatments is that it's going to harm or destroy your bone marrow. So what they try to do is before they start your radiation or chemo, they may go in and harvest as much of your bone marrow as they can, give you the chemo, and then after your treatments, they put your bone marrow back inside you so that the chemo doesn't destroy all of your bone marrow. So that's autologous, when they take it out of you and put it back in you later on. You can also do it for surgeries. If you're having a surgery that can be put off for a couple months, like a knee replacement, you might go in during that 2 months and donate as much of your blood as your body will tolerate. And then when they do your knee transplant, they give your blood back to you, and you're not getting blood from somebody else. So I don't know if the people who are Jehovah's Witness and that type of stuff, the religious issue where they don't have blood transfusions, I don't know if autologous would work for them. Is it the matter of them getting blood from somebody else, or is it the procedure itself that they're against? If it's just receiving the blood from somebody else, then maybe they could do autologous transplants, donate their own blood, and then have it put back in them during the surgery. So your body isn't stressed by trying to replace so much blood at one time. So that's autologous, when they're going to take it out of you and then put it back in you later. And many people will do that when they have to have bone marrow transplants for chemo or after chemo or radiation therapy. Now, those people who need these more than anybody else are probably the people with leukemia. Their bone marrow is not producing the right or the blood cells correctly. And as a result, they are anemic. They don't have enough blood cells. They don't have enough white cells, red cells, or any of that. So we will transplant somebody else's bone marrow into them and kickstart their production of blood cells as long as that bone marrow will last. And then they may have to have another bone marrow transplant a year, a couple of years from now, or whatever. All right, so that is where what we do when we're taking bone marrow out of somebody. Remember, for your testing, that red bone marrow produces the blood cells, all of the blood cells. One of the mistakes that people make is they try and put two and two together when talking about this stuff, and they believe that red bone marrow produces the red blood cells. But that bone marrow produces all of the blood cells, the red and the white ones. And then yellow bone marrow is fat storage. That's a little bit about our bone marrow and what a bone marrow transplant might look like, going into the hip to pull that bone marrow out of there to transplant to somebody else. All right, so that's all the potatoes. Now let's get to the meat, the human skeleton, and let's name these bones. And I'm anticipating our guest speaker showing up here any minute now. Once we turn that over to him, he'll be the presenter for the rest of the day, and we'll finish up with the bones tomorrow. We should finish a little bit early tomorrow. So if you got homework or a test that you are preparing for, the last couple of hours tomorrow would be a good time to get to that. All right. So 200 before I go any further, if you are leaving me, if you're going to another instructor after this class, you poor things, make sure you get over to the school, pick up your books. You got to take the med-term book over there, and you got to pick up your PCT, MA, whatever class you're going into next. And remember, the building usually closes about 4:30. So get over there as soon as you can. Matter of fact, if we plan to finish class early tomorrow, that might be a good time to go on and do that. Okay?
Sir, how do we know if we're going to another class?
How long have you been with me?
The first module and then this one.
This is your second module,
Mm-hmm.
and you're going to another class.
Okay.
So if you started with me on 7/6, you still have 3 weeks left. If you've already done the anatomy and physiology, where we talked about the heart and the blood and all that stuff, then you're ready to move on to your new teacher. Poor things. Poor babies. All right. So anyway, and don't be coming to my class. Talking about this, oh, I just wanted to come back to your class and dot. Because I ain't gonna let you in. We got other things to be talking about. So anyway, there are 206 bones in the human skeleton. You should know that. And this is not like the muscles where we say we have more than 700. We won't give you an exact number because there are so many of them. But in the bones, yeah, it's a finite number, 206. Now, we're going to be naming all of these, but like I said yesterday, remember that 206 bones doesn't mean 206 names. Because if you really think about it, or if you give it a little bit of thought, you'll realize that we have almost two of almost every bone. For example, you have 2 upper arm bones, 2 lower arm bones, and so on. So that almost cuts the list in half right away. When you realize that you have 26 vertebrae, that's 26 bones named by just one name. And the bone that we have the most of are phalanges. We have 56 of those. So that's 56 bones, just one name. Another 26 with just one name. And then another 24 are ribs with just one name. And then take the rest and cut that in half, we'll end up with about 45 names. Okay. So 206 bones total. And we're going to start at the top of the head and work our way down. Now, let's start with the idea. Have y'all ever heard that children have more bones than adults? Has anybody ever heard that?
Yes.
Okay. Actually, what they have is more names. Because once the bones fuse together, we call them by one name. And this is a good example of that. If a child breaks their forehead bone, the doctor is going to call that the frontal bone. An adult breaks the same bone, doctor is going to call it a cranial fracture.
Oh, is it because of those sutures? Because they haven't gotten together yet?
And once they get together, they're all one name now.
Okay.
So children do, when we're referring to their skeleton, we use more names because we're going to still name these individual bones. In adults, all of those are referred to as the cranium. So you should know that the skull bones are known collectively as the cranium. All right, but it's a total of 6 bones. And if we did if you did the brain with me last module, all these names are familiar because the bones are named the same as the lobes of the brain. There are also 6 lobes of the brain. And the first one is our frontal bone, which makes up our forehead. And you see it in yellow. Okay. Your frontal bone. The next 2 are the parietal bones. They make up the top of the skull. There's one, and then the 2 is on the other side. There's a suture down the middle of them, separating them into 2 bones. So they make up the top of our skull with their suture down the middle, the parietal bones. The bones above our ears, in this illustration, you see it in orange. And your ear would be right there. Or excuse me, right here. So the bone above your ears is called the temporal bone. Your ear is right here. It's a big old ear, but y'all get the idea. Right above the ears, the temporal bone. And there are 2 of those, one on each side. The bone at the back of the skull on the illustration is in green. Is pronounced occipital. The bone at the back.
So, Mr. Mental, sorry,
Yes.
the ones that are more bold, are those the ones that we're needing to know?
Now these down here.
Okay, just the red. Okay.
Just the stuff in red. Yep. Okay, so the parietal or the frontal bone, there's 1, 2 parietals, 2 temporals, and then the occipital bone at the back of the skull. And you know, when babies are born, these are not knit together. The sutures between them is what indicates bones. 1, 2, 3, 4. All right. So the bones of the skull collectively are known as the cranium. Okay, I'm going to bring this up a little big so we can see these a little bit better. Some of them will be difficult to see. The frontal makes up the top of our eye sockets. As you can see, this is all frontal bone right there. And this is the top of the eye socket right there. So the frontal bone actually doubles as a facial bone by making up the top of the eye socket. The inside of the eye socket towards the middle, the first one we're going to find is the nasal bone right here in green. Now there are actually two of these. They're separated by a suture down the middle. And when you break this bone, a little bit thicker with this. That's right there. When you break this bone, there is nothing really to pin it to or cast it to. So we're actually going to take that bone and just snap it back in place. Put that piece of tape on there for to help keep it from moving around, and let it grow back into place. If you break your nose and you don't have that bone reset, you're going to end up with a funny looking nose, like Owen Wilson. I don't know what happened to that man's nose, but he should have got that fixed. I'm sorry. So if your nasal bone is broken inward, then your nose is going to dip in a little further than normal. Oh, your nasal bone was pushed backwards like that. And that's how it'll heal if we don't fix it. Now imagine it squeezing off your nasal passages as you're trying to breathe through your nose with this thing pushed backwards like that. Yeah. The good news is that if you come into the emergency room with your nose broken backwards like that, we're just going to take a probe, stick that up your nose, and then snap it forward. Kind of like up and then boom, snap it forward. And that'll bring you the bone right up back into space, into spot again. Okay. If you have the nose where the bone is broken outwards, then you're gonna have that Dick Tracy looking nose, the one that comes out kind of like whenever they illustrated Dick Tracy in the comic books, he always had a square nose. Okay. So you're gonna have that nose sticking out like that. Now this is where the doctor is going to put the probe up your nose, and then they're going to put their finger on the bone and just snap it back. Probe so it doesn't go too far in, and then just snap it back. If you're unlucky, you get that where somebody punched you in the face and broke your nose to the side like that. And you have that really weird looking funky move to the side nose. Again, same thing, we just put a probe up there and snap that thing back straight again. So, but if you don't get these things reset, as you can imagine, breathing through your nose is going to be a little more difficult. Yeah. These things aren't set correctly. That's your nasal bone right there. Again, you break it backwards, you break it outward, or you break it to the side. All right, now inside the eye socket, right up in here, you see there are actually two bones, one orange and one pinkish looking color. The orange looking one with the big dot is your lacrimal bones. They're called that because the tear ducts go through these bones. And the things associated with our tears and production are lacrimal, like the lacrimal glands and the lacrimal duct. And the lacrimal duct passes through the lacrimal bone. So there's one on each side, right on the inside of your nose right there. And then the one all the way in the eye socket, you can barely see it in there in orange, is your ethmoid bone, right in here. And there are two of those. Other facial bones include the zygoma, your cheekbones. It's in white right there on each side. And people sometimes have their cheekbones broken. They've been hit in the face with something, or they've fallen skateboarding or something. and boom, crack that bone right there. And you see it also makes up the outside of the eye socket. So you break the zygoma, and yeah, you could poke out an eyeball if that thing gets pushed inward when you fall on it. So the zygoma are your cheekbones. Remember that muscle we talked about yesterday? I think it was the zygomatic, the muscle that came across the zygoma and down the face like that. So the zygoma is your cheekbones. The upper jawbone, this yellow right here, the bone that holds your upper teeth. That's your maxilla. And that's where we get the term maxillary. Some doctors out there are maxillofacial surgeons. They work on problems specifically with this bone. Because this is the bone that makes up the roof of your mouth, and so on. Well, it doesn't make up the roof of your mouth, but it joins the bone that does make up the roof of your mouth. So people who want to be maxillofacial surgeons usually start out as dentists, people involved with teeth, and they go on into specialty. So the maxilla, the upper, it holds your upper teeth in place. And then the lower jawbone is your mandible, the big one in blue. If you look right here, this is the opening I was talking about, the foramen that allows nerves to come out to the front of the chin right there. So that's your mandible bone, the big one in blue. Now that gives me a chance to mention that whenever two bones make a joint together, like in this case, the mandible right here joins with the temporal bone right there at this joint right there. That joint is named after the two bones. So whenever two bones make a joint, we call that joint by the name of the two bones. For example, this is your second metacarpal phalange joint. Or yeah, metacarpal phalange joint right there. The metacarpal and the phalange bone. Now this joint right here causes some problems for people in their life. That joint is called your temporal mandibular joint, or TMJ, your temporal mandibular joint. And again, it is right there where the temporal bone makes a joint with the mandibular bone. And why are we spending so much time talking about that joint? Because a lot of people are going to have joint problems with this joint in their life. This is where your jaw hinges to open your mouth. And if that hinge gets jammed up somehow, we're going to call that a temporal mandibular disorder. You've got a problem at the TMJ. And you might feel some snapping or popping when you open and close your mouth, where the joint is just not riding in its socket the way it's supposed to. You might feel when you open your mouth. Okay? You might feel a little bit of pain at the side of the jaw when you bite down on something because your TMJ is dislocated. Now, the way we're going to fix it. Yeah, your TMJ. Did you say so? What'd you say, Chris?
Oh, I'm repeating the words so I can remember it. I'm sorry,
Okay.
I was on mute.
Yeah. If you have a problem with this, the way to fix it is to take your jawbone off completely, realign it, put it back in place, and then wire your mouth shut for about 4 or 5 weeks. Yeah. So unless it's causing major issues for you, I think you probably just leave it, deal with it. Major issues would be, is it causing migraines? Is it causing headaches for you? Or do you have severe pain? Severe pain would be that there is and this illustration doesn't show it very well, but there is a little notch passing right back here, right back behind that bone. And that allows a nerve to come down through there that goes to your upper teeth, lower teeth, and down underneath the jaw. passing right behind the mandible right there. And that's called your trigeminal nerve. And how many branches does it have? 3. Try. Now, if you dislocate this bone backwards, it's going to push against that nerve. And that's going to hurt like a son bitch. Have anybody ever had a brain freeze? Now remember, this is the nerve that goes to the roof of your mouth. So this is the nerve responsible for brain freeze, this branch right here. It's called trigeminal hyperesthesia. If you push this backwards onto that nerve, it's like a permanent brain freeze. Now imagine that going on inside your head. The condition, the actual name of it is, I just pushed the wrong thing. It's not letting me push with my pen, so I got to do this. I hope I spell this right. Tic Delarue. You're compressing the trigeminal nerve back there, and you get that sensation of permanent brain freeze. We need to go in and fix that. You can't walk around like that all the time. That's painful as hell. I've never had one, but I've had patients come in complaining their brain freeze. I got brain won't go away. And these are grown people in tears, y'all. It's painful as hell. And they fell during a football game. One guy, he fell that, it was a local game. They just, throwing ball, that little flag football thing. And the guy fell on the ground and hit his chin just like that on the ground. And boom, pushed that right back up against that nerve. And we scheduled him for surgery. There was nothing we could do for it. So that is the tic Delarue, when you push that nerve or that bone back against that nerve back there. And I think I have a slide actually. Next, I need to trust my slides. And there it is, tic Delarue. Or I think that's spelled wrong. R-E-A-U-X. Tic Delarue. Yeah, still wrong. Anyway, you know what? Let me go and look it up because I want to get it on here right. Oh, stop. Really? How about I just do this then? L-A-R-O-U-X. I thought that's what I typed. L-E. L-A. R-O-U-X. Like the L-A-R-O-U-X. It doesn't look right, but L-A-D-E-L-A-R-O-U-X. Well, one word. Tic Delarue. Anyway, it's spelled right. Tic Delarue, compression of the trigeminal nerve right back here as it comes through this canal right there at the temporomandibular joint. All right, and the type of pain associated with that. So let me save this since I did respell that. All right. And that is the facial bones. 3 of them I ask about on your testing. The cheekbones, the upper jaw, and then the lower jaw. The zygoma, the maxilla, and the mandible. Okay, let me check. Wendy, Tyler. Okay, Alan still hasn't shown up yet. It's 1:45. Alan, you here? Okay, not yet. We're still waiting. I want to know if I want to go on and get into this now. All right, we'll start. If we stop in the middle of this slide, this is where we'll pick it up tomorrow. Okay. So the vertebral column from our skull, moving down the backbones now. The backbones are known as vertebra, and plural is vertebrae. If you want to make a word that ends in A plural, you add an E. So vertebra becomes vertebrae. So I have 26 vertebrae broken down in these categories. The first set are called cervical vertebrae. There are 7 of those, and they are illustrated in red in this illustration. So we have 7 neck bones, cervical vertebrae, because cervical means neck. So we have 7 neck bones. Does anybody know how many neck bones a giraffe has? Anybody want to guess? What'd you say, Chris?
30 bones. 30 bones.
A giraffe has 7 neck bones.
Damn it.
Same number we have. It's just that theirs are real big. Freaking big. So we have 7 cervical vertebrae or neck bones. Now I do like to, can I do it here? Mention that the first 2 of those cervical bones, they would be numbered C1 through C7, because there's 7 of them, the C for cervical. I do want to mention that C1 and C2 have a very important function for us, C1, C2. C1 is called the atlas, and C2 is the axis. And what they do is, atlas is a round bone or circular. The C1, doggone, this is all backwards to me. The C2 is the axis. The atlas fits over the axis and allows you to turn your head. So these 2 bones allow head rotation. And if you get some fusion or damage at those 2 bones, it's going to affect your ability to turn your head. And I think that's what happened to Sylvester Stallone in one of the Expendables movies. They said in that one stunt where he was knocked back against the wall, he hurt his back. I think the news got it wrong, because in the second movie, he seemed to do this a little bit too much, where he turned the entire body rather than turning the head to look over. He would turn like that. So I think he damaged the C1, C2 in his neck. So anyway, welcome, Alan. Good to see you. Hey, unmute. Unmute. No, unmute your mic. Bottom of the screen, little red microphone with a line through it.
There we go. Sorry.
There you go. All right. Good to see you this morning. We were waiting for you. We had the power go out today, so we was wondering if there was going to be an issue with that. So have you used Zoom before?
I have. Yeah. So I think I know what to do
Okay.
as far as like sharing my screen and all that stuff.
All right. So I'm going to go, if you're ready, I'm going to go on and make you the presenter. Where we at? There you are. More. I want to make you the host. Once that starts, everything's going to be on you. You can have them until 1 o'clock.
All right.
All right, everybody. This is Alan. I'm not going to try to pronounce your last name. It's Mauricio.
That's correct. Exactly.
Mauricio. All right. From the San Antonio AIDS Foundation. He's going to talk to us a little bit today about HIV and some of the where that's at today. I know we lose sight, in the pandemic and all that. We forget that there are these other things are still out there, man, and they're still an issue for us. We really enjoyed your presentation last module, Alan. I don't know if I got back with you and told you that. I was a little jealous last time. It's like another man dancing with your wife and dances better than you do. So I'm going to go on and hand it over to Alan, guys. If you have any questions, remember you need to unmute your microphone, ask the questions, and then remute so that you're not bleeding over the whole presentation. All right. So I'll be here and I'll be watching. So Alan, I'm going to hand it over right now.
Awesome. Thank you, sir.
All right. And it's all yours.
Okay. Let me just get this set up really quick. So first off, good morning, everyone. Again, my name is Alan, and I work with the San Antonio AIDS Foundation. And so basically what we do at this organization is that we help and provide services to people who are living with HIV/AIDS. And we've been around for a very long time. We've been around since the 1980s, 1986 to be exact. And so how this got started was the founding father of our organization. His name is Robert Edwards. He went by Papa Bear. He's since passed away in 2016. But in the 1980s, when this whole HIV/AIDS epidemic first started, if you were around in the 1980s, when this all was happening, people were really scared to be around someone who had HIV/AIDS. And so Robert Edwards had a bar in downtown San Antonio, and he wanted to make sure that people who were living with HIV/AIDS were being taken care of, because a lot of people were turning them away. It was a very ugly time in that era. And so he was providing people hot meals. So free hot meals, breakfast, lunch, and dinner. And that's where the organization got started. And so today we are the oldest HIV organization in San Antonio. And so now the services that we provide are a lot of different things. So we have our care clinic, which we have an infectious disease doctor on site who helps take care of our patients when they have their appointments. We also have our short-term housing, or our transitional housing. And so basically what this is that if someone's living with HIV/AIDS and they're homeless and they don't have a place to live, they could come and stay living in our household for about 6 months until they can get back on their own feet. We also have case management services. Our case managers do a lot of different things. So for example, let's say if you go in, you get tested for HIV, and then your results comes back showing that you are HIV positive, meaning that your results that you do have HIV. So usually a person is very emotional at that point. Our case managers do a really good job at counseling them. They also set up their doctor's appointments, and they also help set up their HIV medication. So HIV medication is really expensive. It can cost up to $3,000 a month for HIV medication alone. So it's not cheap. So our case managers find ways to get it for free for our clients, because most of our clients, they're homeless or they are at the low income bracket. So clearly $3,000 a month is a lot for a person to handle. We also, again, have our hot meals program. So 365 days out of the year, clients who are living with HIV/AIDS, they could come by our facility and get free breakfast, lunch, and dinner. That includes holidays. So that includes Thanksgiving, Christmas, New Year's Day, and apparently it includes pandemics as well. So we are still open. We're still making sure our clients are being fed. And then so because of the pandemic, clearly they can't come and sit down in our dining hall anymore. It's all food to go. So they come and take their food to go. We also have our on-site pharmacy. So our pharmacy is open to the public. So it's just not for our clients. Anyone can come to our pharmacy and get their prescription or whatever they need from our on-site pharmacy. And then also we provide mental health counseling to our clients as well. So as far as the prevention part, I'm part of the education team. So my main focus is to go out and talk to the public, which is majority is usually high schools and middle schools. But we also speak to adults as well. But the reason why we primarily speak to the younger kids is because the age group between 13 years old all the way up to the age of 24, that's actually the largest age group that has the most sexually transmitted infections in San Antonio. So if you have teenagers or if you have young brothers and sisters, not saying that they're sexually active, but a lot of teens are becoming sexually active at a younger age. So it's important for them to learn this education because they take up more than half of new infectious STIs that's happening in our city. But it's important for adults to learn this information still. So even you as adults, because if you do have a child, you want to make sure that you're telling them the right information when it comes to sexually transmitted infections and HIV, because I still have a lot of adults who still believe that you can still get HIV from sitting on toilet seats. So if you have the wrong information and then you're telling your kid this information, then they're going to have the wrong information too. So that just kind of makes things worse for everyone. So we want to make sure that adults have the right information too. And this stuff is always changing. I myself still have to get updated on this stuff because this stuff is always changing. We also provide free HIV and syphilis testing at our facility, and I'll go into more detail about that towards the end of the presentation. But so far, does anyone have any questions about anything I covered so far?
No, none.
All right. Okay. So just, I usually like to engage, but I guess it's kind of different for Zoom, but can someone tell me what you know about HIV so far, or what you think you may know?
It's only transmitted through sexual contact or through bloods, usually sharing needles. If an open wound and someone has an open wound and they somehow touch. But other than that, it's not airborne. It's safe to be around someone. Even the perspiration won't scare me. As long as I don't have no open wounds. So as long as I don't have no open wounds, I really am not scared to be around nobody. They can live a long time now because of the medications. They can live a normal life today better than they could back when it just came out. What else? I think that's about. I mean, it's still a very dangerous disease because people, it can kill because of their system. It attacks their immune system, making it weak, so it's hard for them to defend themselves over a common cold.
Chris, can you use your microphone, please?
And there's a prescriptions to like help prevent HIV.
Yes, absolutely. And we'll cover all that as well. So yes, thank you for participating. Thank you for your feedback. So HIV, we're going to dive into it. So I'm going to go over some basic information really quick, and then we'll go into more of like what HIV is like today. So just real quick, as you know, in the case that some of you, you know, don't know what HIV actually stands for. HIV stands for the human immunodeficiency virus. So the H, which stands for human, meaning that you're going to get this virus from another human. This is probably my favorite word in HIV because it's important for people to understand that a person living with HIV, don't forget that they're human first. You know, whether they have HIV, if they don't have HIV, if they have a different disease, we're all human first. So, you know, keeping that in mind that no matter what disease anyone has, human first, right? But this also tells you that you cannot get this through casual contact. So casual contact will be anything like kissing, holding hands, hugging. That's typically what we consider casual contact. Other ways that you're not going to get HIV is through masturbation. We put this in here because, again, like I primarily speak to a lot of high school students and also middle school students. So believe it or not, a lot of sixth graders always ask the question at the end of my presentation. They're like, sir, can you get HIV if you jerk off? You cannot give yourself HIV. Okay, so masturbation, you cannot do that. You can't get it through that. You're not going to get HIV from mosquito bites. That's another common question that even adults ask all the time because they think like, okay, I killed a mosquito, I saw blood. What happens if that wasn't my blood? So HIV cannot be transmitted into a mosquito because it can only survive and live and thrive in a human body. So it cannot survive in a human, it cannot survive in a mosquito. So you cannot get HIV through mosquito bites. You can get other diseases, but HIV is not one of them. And you're definitely not gonna get HIV from sitting on toilet seats. You can't get HIV from sharing food or sharing drinks with someone who has it. And the reason why that is because HIV has to get directly into your bloodstream. The I stands for immunodeficiency. So it's a big word, but if we were to break down the word, the first part is immune, which is your immune system. HIV basically attacks your immune system. We can't live without, as humans, we can't live without our immune system. And then deficiency basically means that there is something wrong with a person's immune system. And the V standing for virus, which means that this just lets you know that it's not curable. So once someone gets HIV, they're gonna have HIV for the rest of their life because there's no cure for this at this time. So with that being said, back in the 1980s, 1990s, HIV was considered a death sentence in those times. So yes, if someone contracted HIV, it was almost a guarantee that they were gonna die from it in a matter of years. And that's what we saw. We lost thousands and thousands of people to HIV AIDS. But luckily in 2020, we're not seeing that as often. And the reason why that is because now we have really good medication to give to our patients and to give to our clients. And so what this medication does, it basically controls the virus. It slows it down. Clearly it can't stop it, but it slows it down to where it keeps a person's white blood cells. So our white blood cells, if you don't know this already, our white blood cells is what helps us stay healthy, right? So HIV basically attacks a person's white blood cells. So when you don't have enough white blood cells, it's easier for a person to get sick. So what this medication does, it slows down the process of HIV attacking white blood cells. So that way a person can have a healthier immune system. So if you look on the very last line right here where it says undetectable equals untransmittable, this is a very important line or very important to remember. Undetectable means that a person is still living with HIV because there's no cure for it. But undetectable means that a person is taking medication, and that medication is suppressing the virus, and this person can no longer transmit HIV to someone else through sex. So that means if they were to have sex with someone, even without using protection, as long as they're taking that medication every day and they're undetectable, they cannot transmit HIV to their partner, even without using protection. Okay, so that's very important for people to understand, because for multiple reasons, because let's say if you meet someone who has HIV and you're like, oh, you know, I still hear a lot of people like, oh, I could never date someone who has HIV. Well, the thing is, that's completely a personal thing, but if you're not dating them just because they have HIV, then, you know, this is the part where you want to educate yourself, because again, if they're undetectable, you can't get HIV from them. So yeah, so a person can't transmit HIV to their partner. Any questions about that? Alrighty. So we do have preventative medications out there that prevents a person from getting HIV. And so this medication is called PrEP, which stands for pre-exposure prophylaxis. And so this is a daily pill that someone can take every day in order for them to not get HIV. Now, who's a good candidate to take this pill? Basically anyone who feels like they need it. Okay, so if you, let's say there's an individual out there who's out there having casual sex all the time, they're not always using protection, then this is something that they can take. This is another option for them to take in order for them to not contract HIV. So this medication only prevents HIV. It does not prevent against other sexually transmitted infections. So yes, you can still contract the other STIs. It just prevents HIV. This is the medication that you can get from, if you have a doctor, usually that's the first place where I tell people start. Ask your doctor about PrEP. Or if you don't have a doctor, there's a lot of places. If you live in San Antonio, there's a clinic called the Kind Clinic. And so Kind Clinic is basically a PrEP clinic. And so they specialize in PrEP. And so they have an infectious disease doctor there. And so they can set you up to get on this medication. So it's a daily pill. So you take it every day. So that is available to anyone who feels like they need it. We also have another medication called PEP, which stands for post-exposure prophylaxis. And so this is basically after if you were exposed to HIV. So let's say if you're a nurse or you're a doctor and you're working with a patient who has HIV, you're drawing blood for them, and then you accidentally stick yourself. Clearly, that is going to pose you at a risk of contracting HIV. So usually there's protocols when you work in a health environment. And so, you know, you want to inform your supervisor, and usually they'll take measures depending on what the situation is. So in this case, if you were exposed to HIV, they will put you on this medication. So you have 72 hours to start this medication. So that's 3 days from the moment that you were stuck with that needle, or whatever situation you're in that you were exposed to HIV. You have 3 days to start it. If you go past 3 days and try to start the medication will not work. And then usually you have to be on this for about 28 to 30 days. And then after you're off the medication, you have to wait 3 months, and then you'll test for HIV. In most cases, your results will be negative. Any questions about PrEP or PEP? So this is also important for PEP as far as the post-exposure. This is also available in emergency rooms. So in the case that a sexual assault victim was raped or any kind of situation like that, this will be another thing that they may need to be put on in the case that, so they won't contract HIV. All right, so AIDS stands for the acquired immunodeficiency syndrome. Basically what AIDS is when someone who has HIV, if their virus progresses and gets worse, it can advance to what we call an AIDS diagnosis. So basically this is just the advancements of HIV. So today in 2020, we see less people being diagnosed with AIDS. Just because a person has HIV, more people are not going to advance to AIDS at this point. And the reason why is because now they have medication to help them to stay healthy, and they won't progress to this diagnosis. It can still happen. It does still happen, but we see way less of a diagnosis of AIDS happening to people living with HIV. And again, that's because of medication. Okay, so as I told you earlier, that HIV has to get into your bloodstream. So HIV can only survive outside the body for about 10 to 15 seconds. So once the HIV has been exposed to the air or oxygen, it dies very quickly outside the body. So it cannot survive outside of the body. So up here, you're gonna see this color wheel. You're gonna see all these different body fluids that come from humans. So if someone is living with HIV, HIV lives in all these fluids, but only 4 of these fluids can actually transmit HIV. So can you guess which 4 do you think those are?
Breast milk.
breast milk, semen, vaginal
Vaginal
blood,
blood,
and
probably.
vaginal fluid.
Blood.
Very good. Good job. So breast milk, blood, semen, and vaginal fluids. So these are the only 4 fluids that you get HIV from another person who has it, okay? Which means that you cannot get HIV through these fluids that you see now on the screen. So HIV still lives in these fluids, but in very small amounts. The only way for you to get HIV through these fluids is if you were to come into contact with gallons and gallons and gallons of these fluids in a matter of seconds, which I pray and hope that you would never come into contact with these mass amounts of fluids at once, okay? So now that we learned what fluids actually transmit HIV, which again is breast milk, blood, semen, and vaginal fluids, let's talk about the ways that you actually contract it. Okay, so there's only 3 ways that you can get HIV from someone. So the first way is through what we call condomless sex, which means a person who has sex without using protection, right? This is the most common way for people to get HIV. And usually what I tell my audience is that, you know, with my experience in doing and teaching and presenting this information for many years, I can tell you that most people are not going to use protection every single time that they have sex. That's just the reality of things. And so basically what I want to let you know is that anyone can contract HIV, okay? Anyone. The second way for someone to contract HIV is through what we call injection drug use. So these are people who inject drugs into their veins and they share their needle or syringe with someone else. The very last way for someone to contract HIV is through what we call mother to baby. Okay, so these are the only 3 ways for you to get HIV: is through sex without using protection, injecting drugs, sharing needles, and mother to baby. So you cannot get HIV from tattoos, and we'll go over that in just a second. You're not going to get HIV from, again, like sharing food or sharing drinks. You're not going to get HIV from blood transfusions either. That was a thing of the past. So back in the 80s, when a person would donate blood, they did not test blood for HIV or STIs in those days. But since the year 1991, any person in the United States who donates blood, they do screen the blood for HIV and other infections. Okay, so you're not going to get HIV through blood transfusions done in the United States. Any questions about that? Alrighty. Okay, so unprofessional tattoos, because a lot of people ask like, well, can't you get HIV through tattoos? And I always say yes, because anything is possible, but it's not likely. And the only way for you to get HIV through a tattoo is through unprofessional tattoos. So what do you think of when you hear the word unprofessional tattoos? Like where do you
like when they do it at home, like
at home, guitar, like a guitar
sharing
string.
needles.
Yeah, yep, at home, guitar string. Where's another common place that people get unprofessional tattoos?
Yeah.
In prison.
Yep,
Prison.
good job. Jail, prison tattoos, right? I mean, they don't have professional tattoo machines in jail, last time I checked. So no, they're all unprofessional tattoos, right? So whenever you think about getting tattoo or getting HIV through tattoo, do you think the risk is in the needle or in the ink?
The needle.
Probably in the ink because it goes in and out of your system, like it goes through your skin and stuff, maybe.
Yeah.
Yep, you're right. So it's actually the ink. Okay. So whenever a person gets a tattoo, that needle's touching the skin or is hitting the skin, so it's causing that person to bleed. So what's going to get on outside that needle is blood, right? And then they have to go back and get more ink. And so as they dip that needle back into the ink, that blood gets inside of the ink. So the inside of that ink is not exposed to air or oxygen. So if someone has HIV, that virus can live and survive in that ink in a matter of up to 4 weeks. So if that person were to pour that ink back into the bottle and reuse it on someone else, that's where the risk comes, okay? So tattoo shops are considered safe because they are regulated by the state. So there's laws that they have to abide by. So they have to, if you ever gotten a tattoo, they pour the ink into those little caps. Once they're done tattooing that person, they have to dispose of those caps. They can't reuse it. And so that's why it's not likely for you to get HIV through tattoo. So yeah, so again, it can happen, but it's not likely, okay?
I tattoo at home, and even when I tattoo myself and just myself, I don't ever pour the ink back in the bottle. I think that's gross.
Yeah, you're not supposed to either. But yeah, and just to be upfront with everyone, there's never been a diagnosed case of someone getting HIV through tattoos. You're more likely to contract hepatitis C through tattoo needles. Hepatitis C is another virus that's through blood, but you can't get this through needles because hepatitis C can survive outside the body for many days as compared to HIV. It dies in a matter of 10 to 15 seconds. All right, so mother to baby. So whenever a person becomes pregnant, Usually what happens in the beginning of that person's pregnancy, they go to the doctor to make sure that they are pregnant. And then they also go to the doctor because the doctor wants to screen them to making sure that person's healthy. And so by screening them, they actually do an HIV test and they test them for STIs. So they actually test the mother in the very beginning of the pregnancy in the first trimester, and they test the mother again in the third trimester, which is the end of the pregnancy. So the reason why that is because in the case that that mother does have HIV, the doctor is going to make sure that she's placed on HIV medication. So that way the virus is not transmitted to her baby during pregnancy. Okay. So that medication will not transmit, so that medication will prevent the virus being transmitted to the baby during the 9 to 10 months. So to give you a better example, one of my friends, she's been living with HIV for many years. And so, you know, a few years ago or many years ago, she decided that she wants to start a family. So she got pregnant. She's had 3 babies. And so her kids are grown. They're all under 10 years old, and none of her kids have HIV. And the reason why that is because she takes HIV medication. So HIV was never transmitted to her kids. And actually, to be more forward, both her and her husband have HIV. And so their kids that they have together, they do not have HIV because of the medication. So that's why, again, medicine has changed so much over the years. A person living with HIV can still have a family of their own. So that's very important for people to understand as well. Any questions about that? Alrighty. So injection drug use. So what you see here on the screen is what we call hypodermic needle or a syringe. And so if you look on the right side of the screen, that hypodermic needle, that just means that it's called a hypodermic needle because it's hollow on the inside, which allows fluid or blood to travel through the inside of that needle. So the inside of that needle, there's these little zigzag walls that go back and forth, and they're called microscopic serrations. And so whenever blood travels through the inside of that needle, blood will get trapped behind those little serrations. So if they're injecting drugs and they have HIV, that virus can survive in that needle up to 4 weeks because it's not exposed to oxygen. So if they were to share that needle with someone else, they can definitely spread the virus that way. So a lot of people who inject drugs, they tend to reuse their needles, which you're not supposed to, but people tend to reuse them sometimes, and they tend to share. So sometimes they try to clean their syringe using all different types of products. What type of products do you think people try to use?
Probably bleach and stuff, alcohol and crazy stuff.
Sanitizer.
Yeah, they try all different things like alcohol, peroxide, bleach. I've heard Fabuloso. I've heard all sorts of things that they try to clean their syringes with. So basically, so basically there's not a correct way to clean a syringe because these are to be used as a one-time use only. There's not a correct way, so you're just supposed to dispose of them. If you tend to reuse, if a person tends to reuse their needles, I just recommend that they don't share it with anyone else. All right, so moving on. So what types of sex puts you most at risk for HIV? So there's 3 different types of sex. So what are those 3 different types? And when I say types, I mean types, not positions. So what are those?
Oral.
Oral.
I would say, what do you call it? What's a nice way to say this? Rectal, because you can tear the skin and make blood.
Yep. So oral, anal, and vaginal, right? So those are the 3 different types of sex. So out of oral, anal, and vaginal, out of those 3, which one do you think is the higher risk?
Anal.
Anal.
Probably.
Yep, anal sex, then vaginal, and then oral sex, okay? So the reason why anal sex is a higher risk of transmission is because, like Joe said, it's because of the tearing. So the lining of the anus or the rectum is very thin skin, basically, and so it tears very, very, very easily. So just think about it this way. First of all, what is the largest organ that the human body has? What do we have as humans? What's the largest organ?
Brain.
Your liver.
Brain. Liver.
The intestine.
So it's your skin, your epidermis, okay? So the skin is the largest organ that we have, okay? So the lining of the anus is a very thin layer of skin, okay? It's a very, very thin membrane, and so it tears very easily, okay? So let's say if you get a cut on your hand, right? If you get a cut on your hand, do you think that's an opening to your bloodstream? Yes, right? So same thing when it comes to anal sex, the lining, if there's tearing there, that's gonna be opening to that person's bloodstream. So during sex, you have 2 people, you have the receiver and you have the giver, right? So let's just talk about the receiver first. So let's say the receiver is having anal sex, and then so what's happening to them is that they're receiving micro tears. So again, because that skin is very, very thin, there's gonna be micro tearing, which means that is opening to their bloodstream now, right? So that means that the person that they're having sex with, which is the giver, so if the giver is having anal sex with them and the giver has HIV and they don't know it because they've never been tested for it, they can't know that they have HIV, clearly. But if any seminal or pre-seminal fluid gets into those small tears into the receiver, that's how the receiver will contract HIV, especially, again, if the giver doesn't know that he has it. Or, yeah, if they have it, right? So that's just how one person gets it. Now, as I've spoken to like probably thousands of people at this point on this matter, a lot of guys always think that like, oh, well, if I'm the giver or if I'm the top, I can't get HIV, right? And that's, again, that's false. That's incorrect, okay? Because let's say if you're the guy, you're the giver, and you're having sex with the receiver, whether the receiver is a woman or a man, that receiver is going to receive those micro tears, right? So if there's tearing of that person's skin coming from the receiver, what comes out of the skin when there's bleed or when there's tearing?
Yeah, blood.
Blood, right? So blood. So if someone has HIV, HIV also lives in blood. So that means the blood from the receiver can go into the opening of the giver's penis. Or let's say if the giver had a cut or sore on his penis from another sexually transmitted infection that he didn't even know that he had. So if that blood were make contact in those openings, that's how the giver contracts it. So let's go back real quick. You remember the color wheel that I showed you? The four fluids that transmits HIV. So it was blood, semen, vaginal fluids, and breast milk, right? So there's a fifth fluid that wasn't on that color wheel. And this fifth fluid also transmits HIV, but it only pertains to anal sex. And so this fluid is called rectal fluids. So we all have rectal fluids. It's what helps us poop easier. And so there's HIV in rectal fluids as well. So rectal fluids from the receiver, if they have HIV, those rectal fluids can also transmit HIV to the giver as well. So in general, anal sex is the higher risk of transmission because of the tearing and because of the blood and because of the rectal fluids, okay?
That's why it's transmitted. Oh, okay.
Yeah.
No, I'm sorry, I was thinking.
No, you're good. Anyone else have any comments or feedback or questions about this?
No.
So keep in mind, everyone, I'm pretty sure I don't have to say this, but I do have to say this. When I talk about anal sex, don't just assume that it's gay men who have anal sex. I've tested plenty of straight people who have anal sex. I test a lot of women who have anal sex too. So it doesn't just happen in one community. It happens in all sorts of communities. Okay, so it's just not one type of group of people who have this type of sex. But if a person does choose to have anal sex, that's why it's very important that they use lubrication, because again, the inside, hang on, I think my screen froze. Uh-oh. Give me just a second. Uh-oh. Hang on real quick, guys. I think my screen froze on something. Okay, we might just have to do it from here, but that's okay. So that's why it's very important for a person to use lubrication. And so when you hear the word lubrication, that does not mean spits, that does not mean lotions or oils, that is not lubrication for sex. That is actually all very dangerous. Spit clearly dries very easily. That doesn't do any type of lubrication. Lotions and oils, that's made for the outside of your body. Lotions, oils, there's chemicals in there to help dry skin. If you were to insert lotions or oils into the vaginal or anal area, that can actually cause a serious infection. Okay, so that can cause more damage and do more harm. So the type of lubrication that I'm talking about is either water-based or silicone-based lubrication. And so that is, give me just a second. So that is basically stuff that you'll find in the same section where you would find condoms. They would have all that stuff there. Give me a second. It froze. Okay. Give me a quick second. Okay. I think I might have to restart my computer in order for this to work. So I'm going to have to exit and come right back. So if you guys want to take like a quick 5-minute break, would that be okay with everyone?
Yeah, let's do that. Let's break until 11:35. That gives about 12 minutes.
Okay, that works. Sorry about that, guys.
That's okay. All right, Alan, you ready?
Yeah,
All
sorry.
right, turn it back over. All right, it's all yours.
All right, thank you, sir. All right, there we go. Do we want to wait till 11:35 or do you want me to just go?
Yeah, let's give him another 7 minutes.
Okay, that works.
Everybody about ready? I think we might be.
I'm here.
All right. Okay. Whenever
Yes,
you're ready.
sir.
I'm here.
All right. All right. So hopefully this won't happen again. Sorry about that, everyone. All right. So we talked about anal sex. Now let's talk about vaginal sex. So when it comes to vaginal sex, who do you think is at a higher risk of getting HIV? Do you think the person who has the vagina or the person who has the penis?
Male. I mean, female. I'm sorry.
Okay, so the person with the vagina, right? And the reason why that is because the vagina is actually inside of the human body, the penis is outside the body. Also, the vaginal walls is basically like a sponge, meaning that it absorbs very easily. So that means if any seminal or pre-seminal fluid gets into the vaginal walls, that person can actually hold in those fluids up to usually up to 48 hours, which is about 2 days. So by holding those fluids, it gets into that person's bloodstream. So that's why it's easier for a woman to contract HIV. Now, the rule of thumb is that in general, ladies, if you're listening, like it's easier for women to contract sexually transmitted infections in general because of the vaginal walls. Because it absorbs so easily, if you were to come into contact with any bad bacteria or bad viruses, it's a guarantee that the vaginal walls is going to absorb it, clearly, especially during sex. So with that being said, that doesn't mean that guys can't get HIV or STIs from women, because what type of fluid does the woman have that transmits HIV? Think about the four fluids that we talked about that transmits it.
Oh, breast milk.
Semen.
Yep. So vaginal fluids, right? So women have vaginal fluids or vaginal secretions. Vaginal fluids can have HIV in it, and so during sex, when a person's not using protection, those vaginal fluids can go inside through the man's penis. So the urethra, which is the opening to the penis, or again, let's say he had a cut or a sore from another sexually transmitted infection. Okay. So in this case, when it comes to vaginal sex, the person with the vagina is at a higher risk of contracting HIV. But can the man still get it? Absolutely. Okay. So now let's talk about oral sex. So when it comes to oral sex, let's say if a person is receiving oral sex, what type of fluid is getting onto this person?
Semen.
So if someone's receiving oral sex, what's getting on them?
Saliva.
Saliva. Very good, right? So can you get HIV through saliva?
No.
No, right? Because how much saliva would you have to come into contact with?
Whole bunch.
Whole bunch, gallons, right? So you cannot get HIV through saliva, okay? No matter how much saliva you think a person can produce, no human being can produce gallons of saliva in seconds. No one can do that. If someone can do that, I guarantee you that person is not a human being, okay? So the reason why this is important too is because over the years, I've seen a lot of guys who come in to get tested at our facility, and I see a lot of grown men, you know, manly men who are in our waiting area, and they're shaking and crying because they thought they got HIV from someone that gave them oral sex. So I want to reassure you fellas that you cannot get HIV through oral sex. It is not likely to happen. Now you should be getting tested for other STIs. So things like chlamydia, gonorrhea, syphilis, HPV, herpes, you can definitely get that through unprotected oral sex, whether you're giving or receiving. But HIV transmission is just not likely to happen, okay? Now a common question that gets asked a lot though is, what happens if you're performing oral sex on someone and you swallow vaginal or seminal fluids? Can you get HIV that way? What do you think?
Yes.
Okay, so if you swallow vaginal seminal fluids, you cannot get HIV still. And the reason why that is because the stomach acids that we have as humans, stomach acids are so strong and so powerful that actually kills and destroys HIV. So HIV cannot be transmitted through that. Any questions about the different types of sex and the way HIV is transmitted?
No.
All right. So out of those three, which is the higher way or the higher chance of getting HIV?
Anal.
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 Anal sex, right? And can you get HIV through oral sex?
No.
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 Okay, not like it. But you can definitely get the other STIs. All right. So if anyone out there is a fan of dogs or puppies, I'm going to show you a quick picture of my dogs. So this is my dog Buster Brown on the left, and then that's his sister Jojo on the right. They're right outside my door. They're actually like scratching because they want to come in. But these are my little babies. I like to put this in here because clearly what we just talked about is a lot. It's a very heavy topic. So I kind of like to throw in pictures of my dogs to give people a mental break of all the, you know, the breakdown of the other things that we just talked about.
Puppies.
Yeah, they're a handful. They're my little babies. Okay, but keep in mind that there are other STIs out there, like I talked to you about. So STIs, STDs, sexually transmitted diseases, or infections, they're the same thing. You can call it whichever one you want. I just personally like to call them STIs. And so keep in mind that not everyone will show symptoms if you get an STI, okay? So please remember that as an adult. A lot of people, when they, if someone asks them, like, do you have any STIs? Like, no, I feel fine. Well, don't forget that almost like 80% of people will not show symptoms, okay? So the only way for you to know if you have an STI is to go out and get tested. That's the only way for you to know if you actually have one, because most people will not show symptoms. And so if you don't think you have symptoms and then you do have an STI, you can be unintentionally spreading STIs to other people without knowing it. So getting tested on a regular basis is very important, and I'll let you know what is considered a regular basis. So we're not gonna go through I'm not gonna talk about in detail about all the STIs, but I do wanna give you the list. So we have some that are not curable. And so the STIs that are not curable is clearly HIV, HPV, and herpes, okay? So these three, if you were to contract any of these, they're not curable, okay? And just a reality check for everyone who's listening, if you have been sexually active at all in your life, it's a big chance that you probably already have HPV, okay? Most people contract some form of HPV at some point in their life through sex. There's over 109 different strains of HPV, so almost everyone will get some strain of it. It's just that most strains are not harmful to the body, okay? But there are 4 types of HPV that is harmful, that can cause genital warts, and that can cause cancers. The good thing about HPV is that we do have a vaccine for HPV. So if you're under the age of 46 years old and you have not been vaccinated for HPV, I recommend that you go out and get that vaccine, okay? So the other STIs that are curable are syphilis, chlamydia, gonorrhea, and trichomoniasis and hepatitis C. Okay, so these are all infections or infections that you can get that are curable. So this can be treated with medication. And so keep in mind that these do not go away on their own. So if you contract one of these, and again, if you don't show symptoms, it doesn't mean that's going to go away on its own. You have to go to a doctor and get it treated with medication. Okay. Does anyone have any questions about any of these? Okay. Also keep in mind that right now, even though we have COVID going on, it's very important that I need people to understand that even though we're dealing with this pandemic, people are still being sexually active. And so I do fear that at some point there is going to be a spike in sexually transmitted infections because people are still having sex. And right now that's just not being measured, unfortunately, because there's bigger fish to fry in the sea. And so, I do highly feel that we will see an increase on a lot of these STIs in the coming months or in the next few years for sure.
Because there's nowhere to go.
What's that?
Because there's nowhere for anybody to go or nothing for them to do.
Yeah, exactly. So like people are still, people will get bored and, they're still being sexually active. And, the thing is that if a person's not doing it in the correct form, not only could you get COVID, you guys definitely get an STI. Okay, so a big thing that we do at the San Antonio AIDS Foundation is that we try to work on stigma. So if you don't know what stigma means, basically what it is, it's a mark of disgrace associated with a particular circumstance, quality, or person. So basically with me working in the HIV field, I deal with a lot of stigma. I hear a lot of things when it comes to HIV, like, oh, you don't want to get this, you don't want to live with HIV, like that's some gross stuff. And, I hear a lot of negative things. So keep in mind that when people say certain things, it can be very harmful to a person's head, you know what I mean? Because you don't know if you're around someone who's living with HIV, or you don't know if you're around someone who's living with another STI that's not curable. And so people are scared to come out and be open about their status because of stigma. So what I'm going to do, I'm going to put a few words on the screen. And so these are phrases that I've heard over the years, and these are stuff that you may have said or stuff that you may have heard other people say. And so I'm going to talk about them with you. So the first one up here is I'm clean, right? So whenever you go get tested, or if someone asks you, or a partner that you might be sexually active with, they'll ask like, hey, do you have anything? And the most common thing that people say nowadays is, nah, I'm clean, right? So saying the words I'm clean, now you're insinuating that someone who has HIV or someone who has an STI that's not curable, or that is curable, now you're insinuating that they're what?
Dirty.
they're dirty, right? And no one wants to feel that they're dirty because they have something that's not curable. So again, being mindful. So instead of saying the simple words, I'm clean, say like, no, my results came back negative, or I don't have anything. But saying the words, I'm clean, can be very harmful. So let's try to change those words. Another one is HIV is a death sentence. So like I told you in the beginning, HIV is not a death sentence anymore. And the reason why that is because now we have really good medicine to give to our patients. Another thing is full-blown AIDS. So, you know, I'm closer to my 40s. And so like I grew up hearing the term full-blown AIDS. And that's just something that's very old school. I do still hear people say it, but saying the words full-blown AIDS is still something that adds to the stigma of HIV. First of all, this phrase doesn't even make sense. Either a person is diagnosed with AIDS or they don't have it, okay? So a person can't be diagnosed with like 25% of AIDS. Hey, you have 25% AIDS, or you have 50% AIDS, or it just doesn't make sense. So full-blown AIDS is something that's also very negative. And the very last one is they should have used condoms. And this is something that I hear very commonly. And so whenever someone finds out that a person has HIV or they have an STI, like, oh, well, you should have used condoms, bro. You know, like you should use condoms. And the thing is, like I told you earlier, we're humans. We are not going to use condoms every single time that we have sex with a person. Okay, that's just a reality. So basically, we're all in the same boats. We all can contract an STI at some point in our life. Even if you're trying to prevent it, they still happen. Okay, so that's why it's important for a person to go out and get tested. And we'll talk about that in just a second.
Can you still get it with condoms?
You won't, if a condom is used properly, you're not going to get HIV, but you can definitely still contract other STIs with the condom on. So for example, herpes, genital warts, syphilis. So when you think about a condom being worn, a condom's only over the penis part, right? So the pubic area is not protected. So syphilis, genital warts, and herpes, that could be in the pubic area, and that is transmitted through the touch of skin. So if someone's pubic area is touching your pubic area during sex, which is what happens, and even if they're wearing a condom, it can still transmit other STIs. So that's why I tell people you can still get STIs with condoms on. That's why it's important for you to talk to your partner before you have sex with them. Maybe go get tested together or figure something out. If you feel like this person's not trustworthy, then don't have sex with them or figure something else out. Do something that doesn't involve, you know, putting yourself in a situation to where you can contract something, you know, make out, do some hardcore making out or something. I don't know. All right, so what can you do? Okay, so everything I talked about with you all is we're all in this together. It's a collaborative effort. So educating yourself is the first thing that you can do, which is what we just kind of did. Being aware of this information, even though, like I said, we're dealing with the pandemic, like I said, people are still hooking up, people are still having sex, you know, so educate yourself. Secondly is talking about HIV STIs. And so that means if you're sexually active with someone, talk to them about this stuff. Like, hey, when's the last time you got tested? If it's been a while, hey, you should go get tested. You know, COVID-19 is not going to stop people from having sex. It's not going to stop STIs. They're still going to happen. Even if you've been with your girlfriend, boyfriend, wife, husband for many years, I still tell people to go out and get tested on a regular basis. I've tested a lot of people in the past where they've been married for 15, 20 years. I'll test the wife first, she'll test negative. I'll test the husband afterwards, he'll test positive. Clearly something happened there to where someone stepped out of the relationship and contracted an STI. I'm not saying not to trust your partner, but I'm saying you need to take accountability for yourself, and getting tested on a yearly basis is what you can do to help yourself, even if you've been married. And then lastly, again, is getting tested on a regular basis. So usually I say if you're sexually active, get tested at least once a year, minimum at least once a year, okay? If you're a person who has more than one partner, so let's say if you have multiple partners, and that just means if you have two partners, okay, that you're having sex with, then you should get tested a little bit more often. So maybe every 6 months or every 3 months, all right? But for sure, you should get tested at least once a year if you're sexually active. Safer options, you know, not having sex is a great way of not getting STIs, but you know, a lot of people usually don't refrain from sex, or some people do. It just depends on the person. Using condoms correctly and consistently every time. Again, condoms is a great way to protect yourself. So there's a lot of different condoms out there. A lot of people are like, oh, well, I'm allergic to latex, I can't use these. Well, guess what? They make non-latex condoms that's made out of polyurethane or polyisoprene, which is a synthetic type of rubber. And so that way they won't have any type of allergic reaction, okay? They also have the insertive condom, or what they call the female condom, which is basically what the woman or the person with the vagina has, or she has a vagina, she can wear the insertive condom. So that way the guy doesn't have to wear the condom. And so that is also available too. All right, almost done. So window period. So the thing is with HIV is that if a person gets HIV, it's not going to show up in your body the next day. So again, kind of like COVID-19, a person may not show test positive immediately. They usually have to wait. I think with COVID, I think it's like 8 days or 7 days before they'll test positive. With HIV, it takes 3 months for it to show up in your blood. So you can have it before the 3 months, but your blood hasn't developed enough of the virus in order for it to show up in a test. So it takes 3 months after a person's been exposed in order for that to show up in a test. So that means it is possible for you to have a false negative. So if you're in that window period and you get tested too early, your results can show that you're negative, but it doesn't necessarily mean you're negative if you didn't wait to 3 months from when you were possibly exposed. So that's very important as well. All right, so we do provide free HIV testing to the public, okay? So the legal age to get tested in Texas is 13 years old. So if you do have kids and they're sexually active, if they're 13 years old, they don't have to ask you permission to get tested. They can go and do that on their own. So at our facility, we do provide free HIV testing and free syphilis testing. So the test looks exactly what you see here on the screen. So it's a little kit. So you come in, we prick your finger, we draw a few drops of blood, and you have your results in a matter of seconds. So same thing with the syphilis test. We just poke your finger once and we draw enough blood for both tests, and you leave the same day with your results in your hand. Now, because of COVID-19, it's not a walk-in basis right now. So clearly you have to call us and make an appointment. So you can just look us up on our website, San Antonio AIDS Foundation, and you can call us and you can book an appointment and you can come in and get tested for free. And right now, actually, we're doing curbside. So we actually walk over to you with a little tray and we'll do the test that way. So you don't even have to get out of your car. This is our mobile unit. So when things were normal, we would go around the city and do free testing for the public. But we're currently not doing that right now. So we also have a Facebook Live that we do every Monday night. So it's myself and the other person you see on the screen, which is Vanessa. So her and I, we do a Facebook Live on our Facebook page. So we do it every Monday at 7 p.m. So it's not just what we talked about, it's actually more of other things. We interview a lot of people, either people who are living with HIV, or, basically it's evolved around HIV and STIs, but feel free to tune in. It's teenage friendly. So if you have kids, if you want to have them watch it with you, go for it. But it's a more in-depth information, more than what I just went over with you guys. What I just went over with you guys is just basic stuff, but there's more subjects that we cover in this Facebook Live. So feel free to tune in whenever you like. And you don't have to watch it live. You can go back and rewatch our videos on our Facebook page. And then this is where you can go get tested for the other STIs. So if you don't have health insurance, or if you do have health insurance, start with your doctor, go get tested there. If you don't have health insurance, or you don't want to go through your insurance, you can go get tested at the Metro Health Department, which is on the east side. And so this is by appointment only as well, but this is where you can go get tested. On the right side of the screen where it says the UT Teen Health Clinic, that's for teenagers. Okay, so that means if you have teens who need to get tested, they can go there and get tested as long as they're 13 years old by themselves. And so there's a doctor on site, and they specialize with teenagers. And so, I know sometimes teenagers can be very uncomfortable talking to their parents about this, but if you're like a parent, to be like, hey, if you're sexually active, here's a place where you can get tested. It's your thing. You go do it on your own. If you want me to go with you, fine. But that UT Health Clinic is a great place to get tested for teens. So that's why I recommend all the teenagers get tested. And that basically covers everything. And so does anyone have any questions about anything I went over? All right.
No, we got it. Thank you.
All right. Well, thank you so much, everyone. I hope everyone enjoys the rest of your day. Thanks for chiming in and letting me be part of your class today. I appreciate it.
Thank you.
Awesome.
We appreciate information.
Thank you. Thank you so much. Enjoy your day, everyone. Take
You
care.
too.
I'll be in touch. Alan, I'll be in touch.
Okay, yeah.
Go ahead and click on my picture. You'll see 3 dots over there.
Okay.
And that'll give you a option to turn over the
Okay, so I'll hit make host.
3 dots and make host. Yes.
Okay.
Thank you. I'll be in touch.
There you go. Thank you, sir. Appreciate it.
Mhm.
Enjoy.
All right. All right, guys. Where am I? I don't have. I got the wrong glasses on. I can't see.
Mr.
There
Mahomes,
I am. What?
I'm just saying, don't expect our presentations to be like that.
Yeah. Wait a minute. Did I just share the wrong screen? All right, there we are. All right. So, always enjoy Alan's presentation. I say always. This is just the second time that I have had the opportunity. Excuse me, just a minute. Somebody is like really. Yes. Okay. All right, guys. Yeah, please try to be diligent about muting your microphones. I can do it from here, but then I have to stop and find and mute and yes and blah blah blah. But anyway, I have enjoyed Alan's presentations. A little bit more in the classroom, a little bit more interacting. He's very animated. He moves around the classroom kind of like I do, and kind of enjoys it. Blah blah blah. So anyway, I know it seemed a little misplaced. Yeah, we should have had it back at the beginning when we were talking about bloodborne pathogens and HIV, but his schedule was booked up until today, and he actually did adjust the schedule in order to be able to do this for us today. Otherwise, we'd have had to wait until next week, and then y'all been gone by next week, or half of y'all. So anyway. That's why I did want to get that in there. I usually get it in with the bloodborne pathogens. The last module we did that, it worked out perfectly. This module, his schedule didn't allow that for that. So anyway, that is HIV, guys, in a nutshell. Again, when you gotta know something, talk to the experts. And yes, I know the skin is the largest organ of the human body. But the liver is the largest solid organ of the body. So I wasn't wrong. Forget y'all. Anyway, I guess it was like, I'm like, the liver, is the
Yeah.
Just front me like that in front of my students. Anyway. Anyway, so we'll just spend another few minutes and then we'll call it a day. I want to finish up the bones of the vertebrae. So everybody just kind of settle down, get back into your note taking. And I want to go back and restate the idea of C1 and C2 being the atlas and axis, the two bones that allow us to rotate our heads, or turn your head side to side. Now the vertebrae are, let's get the other numbers down and then we'll talk a little bit about them. There are 7 cervical, the bones of the neck. There are 12 thoracic vertebrae. You see these as the ones that the ribs are attached to. So every set of vertebrae that has a rib attached to it is thoracic, and the 12 appearing in blue. So 7 cervical, the bones of the neck, 12 thoracic, the ones that the ribs are attached to. And then there are 5 large vertebrae at the lower back. You see those in yellow. They are called the lumbar vertebrae. Lumbar, lumbae, lumbo is the lower back, as in that dance, the lambada, moving the lower back. Hey, all right. And then the last 2, one large bone, that's 5 bones fused into one. We call it the sacrum. And at the very tip of the vertebrae is the coccyx, the little one down in purple down there. And that's 4 bones fused into one, for a total of 26 vertebrae. Now, I want y'all to notice how the vertebrae are stacked on top of each other. But a misconception is that the spinal cord travels through the bone itself. What I mean is that if you take a vertebrae out and look down at the top or look at it like that, you'll see that it's actually shaped like this. And people mistakenly believe that the spinal cord passes through this bony section right here. That's solid bone. That's what carries the weight of the body. The spinal cord passes down through this opening, riding along the back of the vertebrae all the way down, with these processes protecting the spinal cord. Yeah. Remember, a projection of a bone that allows tendons or ligaments to attach. Those are processes. So these are your vertebral processes. You can feel them when you touch your backbones. You can feel this one right here. You're actually running your hand on those. Okay? With the spinal cord running through this opening down the back of each, riding along the back of the vertebrae back there. All right, so that's what a vertebrae looks like with the spinal cord running through it. And in the image, the spinal cord is running right along here. It's in red right now, but wait, I've got the wrong side. Right along down through all of those openings back there. So the point being that it doesn't sit in the bony part right here. It runs along the back side of there. Now take a look at the stacking of the vertebrae, and you'll notice that they are not straight. They have these curves in them. And those curves are very important because if you notice the sacrum right here is actually angled forward. And if the spinal cord didn't have this distinct curves in them, your spinal cord, if it went straight, your spinal column would go out like this. Your head would be way out here and your feet back over there. So the spinal column curves like that to keep the head right over your feet. And that allows us to hold our balance. If you wonder how difficult it would be without that, without having your head over your feet, think back to when you were pregnant and how you couldn't get up out the damn chair. The reason you couldn't get up is because you couldn't lean forward to put your head over your feet. Once you lean forward like that, you can stand straight up. Now, if you're sitting back like this and you try to stand up, it's not going to work for you. You have to lean forward first. And pregnant women can't lean forward. So they can't put their head over their feet. But naturally, our spinal column does that for us when we're standing up. When we were walking on all fours, guess what? Our spinal column was curved like this. And that is why when we stood up, guess what happened to our pelvis? It continued to lean forward like that. So our pelvis is actually tilted forward, a remnant of when we walked on all fours. So if our spinal column was straight, it carried us out like that rather than curving back and putting your head right over your feet like it does. All right, so those curves are very important for us. Sometimes those curves are not correct, and you could end up with an abnormal curve in your spinal column. There are three types of abnormal curves. One of them is when the spinal column curves outward like this, and you're facing that direction. We call these people humpback or kyphosis, an abnormal outward curve of the spinal column. Some people are abnormally curved inward, where their spinal column swerves in like that. That's what we call sway back or lordosis. an abnormal inward curve of the spinal column. Kyphosis and lordosis, hump back, sway back, like the old sway back horse has been ridden too much. The third type y'all have heard of before, because I guess it's just a cool word that people like to repeat. But when the spinal column is abnormally curved sideways like that, this is the person looking away from you, and you're looking right at their back, and you see a distinct curve in their spinal column to the side. So a sideways curve is called a scoliosis. You've got scoliosis. Okay. Now there are two types of scoliosis, and scoliosis is the most common of the curves, by the way. And there are two types. One is a scoliosis that comes off of the pelvis. It curves once and twice. And believe it or not, 1, 2, 3 curves is better. Because with 3 curves, you get your head over your feet. With 2 curve scoliosis, your head is way out here. And one shoulder is here and the other shoulder right there. So pretty much one of their arms is coming down the center of their body, kind of like this. They are that far shifted over. And that's going, this arm's hanging out there, and this arm is actually coming down the center like that. And, you know, it's odd walking for them. I'm glad I didn't put my shorts, because I was just about to put my shorts on a little bit. I was like, would I have a reason to stand up? Well, I better just keep my pants on because I might have a reason to stand up. I did put my house shoes on, though. I went down to tie my shoes, and I'm like, what am I doing? Kick my shoes off, went put my house shoes on. And I said, well, I can put my shorts on, too. Wait a minute. What if I have a reason to stand up? So y'all didn't get to see my old ugly legs. So anyway, two curve versus a 3 curve scoliosis. Now, if you have a 3 curve scoliosis, your parents may not even notice, because your head is over your feet and everything just looks okay until you go to gym class. Remember that first day in gym class in grade school? They had everybody bend over so that they could look down and see if there was a curve in your spinal column. And if they did, they sent a letter to your parents. So that is scoliosis, an abnormal curve, sideward curve of the spinal column. But remember this as well, that our internal organs, their positioning is highly dependent on the skeleton. And if your skeleton is shifting over, it's shifting the organs with it. And believe it or not, this person right here, or well, this lung right here is being squished. So through this side, they breathe just fine. But to that side, they're going to have some pneumonias and things like that over there, because that lung is being squished to the side like that. So, and that's what we were talking about in that one kid. Remember the muscular dystrophy video yesterday? They showed the back of the kid's torso, and you could see that crease in their side, indicating that things are being squished right there, and the lung is right there. So that kid's going to have some pneumonias on that side if we don't straighten out their scoliosis. Okay, now what they can do is go in and reshape some vertebrae. And once everything is so what they're having is something like this that's pushing their spinal column over to one side. So we have to go in and reshape all of these vertebrae so that they stack up straight on top of each other. And then they'll typically put in a titanium rod next to that to kind of hold everything in place. And boom, there you go. You're nice up and straight again. Yeah. And again, that takes the pressure off of the organ on this side that was being squished over there. So those are abnormal curves of the spinal column: lordosis, kyphosis, and scoliosis. All right. The other issue, or another issue with our spinal column, is that each one of those vertebrae has a pad of cartilage between them, because they're all flexible joints. You can move and flex between these bones. So the cartilage between them makes these joints. And there are 26 bones, so there are 25 joints in your spinal column. So what if you have degenerative joint disease? Okay. Remember, the spinal cord comes down through all of around the backside of all of these bones, but then nerves pass out through these joints, going out to service the different parts of the body. So if the opening between these two bones is getting smaller, guess what's happening to these nerves?
They're getting pinched.
They're being pinched. And that's called a radiculopathy. A pinched nerve coming out through the spinal bones or spinal column like that. Yeah. I have one up at the upper part of my back because when they did my chest surgery, they cut down the center and they opened all of this. Remember, all these bones are attached to each other. So when they opened all of this, it shifted some bones in my shoulder and in my upper back. So I have a pinched nerve coming out in the upper back like that. It's the nerve that comes down the back of the arm. And tomorrow we'll be talking about this nerve a little bit because it's the one you get when you hit your elbow and you get that funny bone sensation. Yeah, I have that in my arm a lot. Matter of fact, I'm feeling a little bit right now because the nerve is just pinched up there. Now, over years or over the day, actually, when you lie down at night, all of these cartilages between these bones, they all spread out. And then when you get up in the morning and stand up and you put pressure or gravity against them, they start to squeeze down again. So believe it or not, you're taller when you get up in the morning than you are when you go to bed at night. Can be up to about a ½ inch. So we should check people's heights first thing in the morning, not in the afternoon when they've been standing up all day. And you might get that sometimes. You come in, you do a height on somebody and they say, oh, you're 5'9½". Oh, no, I'm 5'10". It's 3 o'clock in the afternoon. Guess what? You're 5'9½". So we get shorter through the day with gravity putting pressure on these discs. Remember, these are 25 discs in there. If each one of them decreases a 1/16 of an inch, that would be more than 1 inch. Now, there was a question on the radio one morning, are you smarter than a 5th grader? They do those questions sometimes. And the question was, you will lose 2 of these in a lifetime. And people were calling in saying children and cars and jobs and spouses and all that. I knew the answer right away. 2 inches. Inches. You lose 2 inches in a lifetime just from these discs getting thinner throughout your life. And they start to compress those nerves coming out through there. So you young folks, let me tell you, getting old, man, it sucks, y'all. You know, they say that youth is wasted on the young. Yeah. All the, you know, it just sucks getting old, man. You end up with DJD and pinched nerves and broken down cartilage and torn meniscus and all this mess with your skeletal system. And that's what I mean when I was saying at the beginning that the skeletal system, once it's damaged, man, that's lifelong damage. Not like a muscle that will heal over time. All right, so anyway, those are all the vertebrae or all the cartilage between each vertebrae with the nerves passing out between them. You get a cartilage that pinches a nerve, and that is radiculopathy. Sometimes these discs can slip out of place, and you'll have somebody who has a slipped disc. Sometimes the disc itself can, you know, there are parts to it, an inner and outer layer. sometimes the outer layer can get rubbed away or damaged, and the inner layer sticks out, and you have a perforated disc. PER. A perforated disc, a slipped disc, a perforated disc, a thinning discs, all are going to cause problems as these nerves are trying to pass out through these bones. If you break a vertebrae, we're just going to take it out and put in a fixator. Vertebrae, broken vertebrae, the other vertebrae. We take this one out completely. And then put in a prosthesis that pins those two. Of course, you're going to lose some mobility at this area, but trying to put another disc in here, you're going to have to find just the right person. But the good news today is that they might be able to print you a disc on the 3D printer. So they can scan the vertebrae, or a vertebrae, excuse me. They can scan the vertebrae and build one out of plastic. And the first place they ever did that in the world was right here at San Antonio, Texas. So the first vertebrae, artificial vertebrae, the first artificial rib was put in San Antonio, Texas. So they do a lot of exciting stuff here, healthcare wise, in Texas or in San Antonio. But has anybody heard? Did anybody see the news last night about Kentucky Fried Chicken?
Yeah, they're making an artificial ring, 3D.
Yeah, yeah.
It's crazy, right?
They're going to start printing chicken nuggets.
It's for vegans.
Heck, gross.
It's for the vegans.
And it's not real chicken.
Yeah, it's for the vegans, so you can get the chicken flavor taste.
I don't want none of that mess. Are you kidding me? It's not real. You're going to print chicken nuggets on a damn machine. Come on in and buy them. I don't think so.
It's like injected.
Yeah, I don't know what that mess is. Anyway, I did go to Taco Cabana this morning. Stopped getting me a couple tacos. Come out to about $3.20. So I pulled around. The girl gave her a $10 bill. She gives me $6 change. I said, excuse me, I thought you said it was $3.20. Oh, new company policy, we don't give change.
Oh yeah, that's gonna do that too.
Girl, you better give my change. Give me another dollar then or something.
I told that child, yeah, you eat the change. You give me $1 then. The company should be eating that damn change if they're not going to give change, telling me I've got to eat the 80 cents. No, tell you what, give me my $10 bill back. Oh, yeah, give me my $10 back. Are you kidding me? Y'all just gonna bump the price up 80 cents because y'all don't give change. Give me my $10 back. You know what she did? She went to the register, got change, and said, well, we'll do it this time.
I know you will.
I was dead serious. You better give me my $10 back. You're not keeping 80 cents of my freaking money because the company policy says y'all don't give change.
So I guess you're keeping my change. They can give us an extra taco or something.
Yeah, you can slip another taco in the bag or something. You know, the company just gonna keep that little 80 cents like boom. You know, the executives. You know, the executives are voting on that. Oh yeah, let's just not give them any damn change, and we'll keep that. You better recognize. Give me my $10.
It's not the only place. They're doing that everywhere. They're trying to. My mom is like freaking out about it. She's like, where you go, they don't want to give you change. Then they want you to give them change. Like if your total is $5.70, they're like, do you have 70 cents? Because they don't want to give you any change. She said they're trying to take change out because of the COVID and spreading. And I don't know. She's like freaking out about it everywhere. Not just Taco Cabana.
And
they're probably trying to force that card.
My wife,
use your debit card.
She does exact change all the time anyway. Gets on my damn nerves. If it's $3.16, oh, I got 16 cents. And she getting all down in the freaking papers, taking an hour, taking the purse and hanging it up sideways to catch change. You know, yeah, there go 3 pennies right there. It's on my freaking nerves, man.
I bet they would stop that if everybody just started started searching for pennies in their car for exact change.
Yeah. Well, here you go. You take the change then and be at risk. You know, what kind of risk is that? Passing change from me to you. So anyway, and all that going in your freaking register.
He's trying to make us use our debit cards, Mr. Mahone.
And I'm not doing that. I'm not a debit person, man.
Your cash.
Yeah.
Same here. I don't like credit cards.
Yeah, I don't like debit cards, not to pay like little stuff like that. When I go and buy something major, yeah. But you know, $1.50 or $3 at the damn store, I don't want to be using a damn debit card. You know, that's how you lose track and forget how much freaking money you got. You're nickel and diming it to death. All right, so y'all, I'm squirming back and forth. I really got to go to the bathroom. I'm going to end class anyway, but stay on if you have any questions. If not, I'll be back in just a minute.
We can leave if we want.
Yes, he said you can leave if you want. I'm just afraid I'm going to do something. He's going to come back and say something.
He's going to come back if anybody has any questions. Yeah.
Yeah.
All right, so does anybody have any questions before we end the class for today? Hopefully tomorrow I'll be back on campus. Remember, if there are any issues, just be patient, and eventually we will be having class tomorrow, and we'll be finishing up the skeletal system and all of those parts. Now, I will go on and do this, since I'm thinking about it. I'm going to go on and send you the skeletal review so that you can start looking at that. All right. I've got to go and someplace else to make sure that I am putting the right one in there. So let me go open that first and make sure it's the right one. I'm going to be sending out something that is not what we're looking for. Today would be nice. I need a new laptop. That's the next thing I'll beg my wife for. I need a new laptop. This one's slow. Really? Uh-oh, here comes Rocky. Maybe I'll put a picture of my dog in my presentations. Yeah, Rocky come
Does
here.
it have to be PowerPoint, or can it just be me answering the questions, like paragraphs?
For what? For the presentation?
Presentation.
No, it can just be paragraphs. It doesn't have to be PowerPoint or anything like that. What the heck is going on with this?
And I know I'm really far behind, but I am trying to catch up.
Okay, hang in there. Don't give up.
I heard what you said this morning about failing the classes.
Yeah, don't give up now.
I'm not planning on failing.
And it's not necessarily a failure, but it can bring your grade down. I think your test scores are good enough right now that it won't be a failure, but it'll pull your grade down. So
Yes, sir.
get that stuff done as soon as possible.
Yes, sir.
Doggone it. You know what? I'm gonna have to type that up tonight and send that to y'all, the review part, because I didn't think I had a review, and I'm pretty sure now that I don't. So I will type that up this evening, and that's the good news. I can do it from home and send it to y'all. So I'll get that sent out this evening. Give you more than one day to study. All right. But where you can start is the red stuff. Remember all the red stuff. Yeah. So you can start writing that stuff down: ligaments, foramen, red bone marrow, chondromalacia, softening of the cartilage. So the stuff you're seeing in red is the stuff you need to go on and start getting ready for that one. All right. And we'll finish this up tomorrow. I will send out the review sometime this evening. Okay. So other than that, are there any questions before we log off?
Yes, Mr. Mahone.
Yes. Uh-huh.
For the people that are the CNA ones, whenever we leave, when will we be receiving our grade for your class?
Within a week.
Okay.
About the amount of time it took me to send it last time.
Okay. Thank you.
So I still got to type all those emails and So
Now, is there any way you can just move on to the class with us? Just like advance with us, Mr. Mahone?
All you poor things. Yeah. No. No. I got to take on my new students and start my new class. And you'll be gypping some of the other students out of the second part that they get to spend.
Sir, I'm bad at adding. How can you explain how to add up so I can know my grade, my overall grade?
All right.
I'm gonna write it down.
Take all four or all the grades that you have right now.
Okay.
Test grade 100 plus 98 plus 76 plus a 64. Add all those together.
100.
Yeah. And where is my calendar? But anyway, add all those together. That's 18, 9, 10, 17, 18, 19, 20, 21, 22, 23. Yes, I did count on my fingers. And then 2 and 1 is 3. All right. And then divide by 1, 2, 3, 4. How many are there?
Okay. And then okay.
So if there are 5 grades there, you divide by 5.
Okay.
All right. And that will give you your test average. And know that if your test average is, for example, your test average is 84, your homework and assignments are going to bring that up 1 letter grade. So right now you'd be at a B, add the other assignments, that will bring you up to A. So 1 letter grade up.
Okay.
Or if you got this on your test and you didn't do any of the homework, guess what happens? 1 letter grade down. So that's how you do your average. Take all the tests that you've taken, and that's why I've told you to write down the grades for every one. Take all of those, add them together, divide by the number that are there.
Okay.
All right. Any other questions? All right, then we'll see y'all tomorrow morning at 8 o'clock. Wait a minute. Why did it let me close? I want to close. I want to get away from y'all.
Oh, that's not nice.
I know, poor me. Yes.